Shall we start?
Yes, please.
Recording in progress.
Good evening, everyone. This is our 75th Republic Day. So I wish you a happy Republic Day to all of you. Today, we are going to start the first Endovision webinar. This is a webinar series which is going to happen on every third Wednesday of the month. And the convener of this webinar is our own past president of IIG and who has many accolades for his own career, because he is the organizing chairperson of AICOG, what we had experienced in the past in Calcutta. And can I have the CV of Bhaskar Pal, sir? Yeah, he is a MD, DGO, DNB, FICOG and FRCOG, Senior Consultant Obstetrician from Apollo Multi-Specialty Hospital, Kolkata. He is the Chair of Endoscopy Committee, SAFOG. He is the Chair of AICC RCOG 2021-23. He is the immediate past President of IIG, a FOXY representative to SAFOG 2021 to
That should be enough, Ashish.
And
that
one
should
more
be enough.
thing, yes, sir. I wish to tell everyone, when you choose a leader, the leader has this ability and vision for an organization. And I must say, Bhaskar Da is one of them whom we should vote for his FOXY elections, because we need a visionary to nurture our organization in the future. So I wish Dr. Bhaskar Pal to give a word of wisdom for this webinar series.
Thank you, Ashish, for the kind words. I welcome everybody to our new series, and this series is called Endovision, and this will focus exclusively on gynecological endoscopy. As you know, that we have a routine obs and gynae series running, and day before yesterday we started a reproductive endocrinology series. My apologies for joining in from the car, because I've just landed for the Chhattisgarh IAG event, and man proposes, but God disposes. So what has happened is that despite all the planning, the flight was delayed, and that's why I couldn't sit in one place and join the webinar. Now, this webinar would happen from next month for essentially a total of 8 episodes. And from next month, it will always happen on the second Wednesday of the month from 7 to 9 p.m. The first one, and all webinars will be of 2 hours duration. Usually, they will have 4 video presentations and 1 panel discussion, except for one which I would like to call the Yuva session, where we would have 12 young endoscopic surgeons presenting video presentations of surgeries, but no panel discussion on that day. But today, on the first day and on the last day, we'll have 2 mega talks by legends in the field of endoscopy. And today we have Dr. Shailesh Puntambekar and Dr. Sanjay Patel to start off that. And when we are looking at who should inaugurate this webinar series, I couldn't think of anybody other than Dr. Prakash Trivedi. So apart from all the other faculties, I would like to specially thank Dr. Prakash Trivedi, Dr. Shailesh Puntambekar, Dr. Sanjay Patel, Dr. Arun Madhav Barua, and Dr. Nutan Jain. So I hope we have a very, very productive session. And I cannot thank the team enough, and the team which is led by Ashish and Subhash Malia. And we have Dr. Paushali Sharnal, Dr. Prerna Keshan, Dr. Amok Chimote, and Subhash Malia has left. And we have Dr. Aditi Tandon. So thank you very much, and have a good viewing. Please put us your requests. We would be happy to get any suggestions on what topics we could incorporate for future programs, anything particular you would want us to have, and also for panel discussions. Thank you, and over to you, Ashish.
Thank you, sir. Thank you for those words of wisdom. Today we have my co-convener, Dr. Subhash Malya. He is the endoscopy committee chair of FOXY. Along with them, we do have a co-convener. I wish to introduce them, Dr. Paushali Sanyal. She is a consultant obstetrician, gynecologist, and endoscopic robotic surgeon from Woodsland Hospital, Kolkata. And along with her, we have a co-convener, Dr. Prerna Keshan. She is a consultant OBGYN and IVF specialist from Assam. She is a YTP is zone coordinator. So along with those, I wish Dr. Prerna to take along this webinar. Over to you.
Thank you,
Prerna.
sir. Thank you so much. And wishing you all a very good evening. And I'm immensely honored to host this first episode of the inaugural episode of the Endovision webinar series, which is aimed at enriching our existing knowledge of endoscopy and beyond. And as the nation celebrates its 75th Republic Day, on this auspicious evening, with this star-studded string of legendary names in the field of endoscopy, we take this honor to commence the very first episode of Endovision 2024. With the brainchild project of Dr. Bhaskar Paul, sir, we are very, very glad that we have taken up this. And with this, we start our first session. And I call upon the chairpersons of the first session, Dr. Arun Madhav Barua, sir.
Prerna, has Dr. Prakash Trivedi joined?
Yes, Bhaskar.
Yeah. Prerna, Dr. Prakash Trivedi has to give his, please introduce, sir. He has to give us the blessings first.
Sir. We have the legendary name of endoscopy with us, Dr. Prakash Trivedi, sir. He is the guest of honor for today's program. And kindly, yes, Dr. Prakash Trivedi, sir, is a name for endoscopy, and we all look up to him whenever it is about endoscopy. Sir is a consultant endoscopic surgeon, ART and urogynecologist, and pioneer of hysteroscopic surgery.
Prerna, don't introduce me. It will take time. With permission of the Chanakya, Foxy, IAG, RCOG, Bengal Society, Bhaskar, one of the wonderful person I know, multifaceted. I'm very happy that we are having this unique program, like other programs which we have, and now we are having so much of talent in India that amongst the senior and amongst the junior, we really find a race wherein age doesn't come into picture. But I am extremely happy to be guest of honor or whatever you tell, because I'm very close to endoscopy, very close to Bhaskar, very close to Bengal, very close to India, and very close to people who are interested in educating. So, Prerna, you and Ashish Kale, and especially two wonderful speakers, Sanjay Patel and Shailesh Puntambekar, not to forget the young brigade of Subhash and so many other people, all these young people. In fact, today only we had twins cesarean section in the morning, then a lap hysterectomy done by Somil. I did a pickup, and now you can see me in an OT dress. So I am there with a friend of mine. Some other aspect we are discussing. But I think so this educational program has made India one of the best place, not only for education, but actually genuine interaction on a holiday, on a weekend, and which goes a long way to show our commitment towards the cause. So big congratulations to Bhaskar and the entire team. I will be visually on, but otherwise I'll be muted. I'll be listening to panel discussions, etc. Because at any age you have to learn. So all the best and have a great event. Thank you very much.
Thank you, sir.
So much, sir. Thank you so much for your words of wisdom. Your contribution towards female health of the nation is truly impeccable. We salute you, sir, for your guidance always and your blessings. Thank you so much, sir, for having you amongst us. We now move on to a scientific session, and with that, we start with the keynote addresses. The first keynote address will be by our legendary figure, Dr. Shailesh Puntambekar. And for chairing the session, we would like to request Dr. Nutan Jain and Dr. Arun Madhav Barua to kindly come up to the dais. Can we have Dr. Nutan Jain, ma'am's CV, please? Dr. Nutan Jain, ma'am, is Director of Vardhaman Infertility and Endoscopy Center, Muzaffarpur Nagar, India. And she has a lot of credit to her credentials, and she is the live telesurgery relay of laparoscopic surgery to AAGL 46th Annual Global Congress in Washington, D.C., USA. And she is also a member of the Electoral Board of International Society of Gynecological Endoscopy 2006 and has been nominated for the AAGL Board of Directors 2009 and 19. She has many prestigious awards to her credit, and we are really, really honored, ma'am, to have you amongst us. Our second chairperson, Dr. Arun Madhav Barua, sir. He is the king of the Northeast, as we say, and my mentor and guide, as always. Can we have Dr. Barua's CV, please? Himanshu. Dr. Arun, yes. Dr. Arun Madhav Barua, currently based at Guwahati, is a consultant Apollo Fertility Clinic and is the chairperson of Northeastern IAG and the founder chairperson of Northeastern ISAR. He is a past president of Dibrugarh OBGYN Society and has been a mentor to all of us youngsters in the entire Northeastern region. We salute you, sir, for being with us in spite of your busy schedule. We now move on to the first keynote address, that is laparoscopic anatomy, bird eye view, by Dr. Sailesh Pundambekar, and I request Dr. Nutan Jain, ma'am, to kindly introduce Dr. Sailesh Pundambekar, sir. Ma'am, are you there?
Sure, yeah. Can you hear me?
Yes, ma'am. Yes, ma'am.
Sure.
Please go ahead.
A very good evening to all, Dr. Barua and Dr. Prerna, Dr. Ashish Kale, Dr. Shailesh. So introducing Dr. Shailesh Pundambekar is like telling people कि मोदी जी ने मंदिर बना लिया. So Shailesh is known all over the world and is the director of consultant oncosurgeon at the Galaxy Care Hospital in Pune. It's a pleasure visiting his hospital and meeting him at the various international forums where he's the star speaker, and all his PG courses on anatomy are star-studded, people sitting on the floors or standing behind the seated benches. So he patented the technique of radical hysterectomy by the name of Pune technique, conducted India's first successful laparoscopic assisted uterine transplant. The baby girl was also born, and we all had the pleasure of meeting the baby girl in Ahmedabad, IAGE, and he's the only Indian to be the board member of AAGL. All of us have had the pleasure of losing 2 times. Then he is the operating faculty at IRCAD and various other international organizations and their conferences. He has the largest published series of transthoracic esophagectomy and known for performing the most difficult laparoscopic endoscopic surgeries. And to this, I would like to add his recently relayed live tele-relay of a uterine transplant in the Celsi Congress in the month of, I think it was October. So over to you, Shailesh, my very good friend, and always.
Before Shailesh starts, madam, I just wanted to say something. I think apart from everything else, Shailesh is a passionate teacher. And the way Shailesh teaches anatomy, I have the feeling that we should actually teach in gynecologist anatomy, not in the dissection hall, but through a laparoscope. And that is why I wanted to kick off this series with a lecture on anatomy by laparoscopy from Shailesh.
Yeah. Perfect.
Thank you. Good evening, everybody. At the outset, thank you, Bhaskar, for inviting me for your first of this webinar. And of course, thank you, Nutan and Arun, for both of you being chairpersons. And of course, it's a pleasure to have Dr. Trivedi as the guest of honor. And I'm very sure, Bhaskar, we are looking at the most future president of the FOXY. All my best wishes to you. We will wholeheartedly be supporting you, no doubt about it. And the capability, I don't have to say about your capability. You're the best organizer I've ever seen in India. So all the best. And I'm very, very sure you're going to win it. We are all will work hard for you. So with these words, we will definitely start this. And I will start my talk on, are you able to see this now?
Yeah.
Yeah. So it's a passionate topic that has been given to me. I have been always passionate about teaching anatomy, irrespective of what you are, whether you're a robotic surgeon, open surgeon, laparoscopic surgeon. Anatomy remains the basis. So hello, everybody. This is a view that I just came from Moscow, and this is a view which is there. So how can you do laparoscopic surgery without understanding what you want to do? And what is the most important thing is anatomy and nothing else but anatomy. So, what happened? Okay. So all you need to know, a knowledge of anatomy is the only area which is very, very important. And knowledge of anatomy, and then how to apply the knowledge of anatomy is most important. We have all learned the anatomy in this particular way. We know that we learned the anatomy on cadavers. And of course, we realize that it is not a great thing to be, 1 minute, huh? What has happened? So just 1 minute. Okay. Okay. So this is the approach which was there in the 19th and 20th century. Today, what is the approach? We are able to teach many people through one single laparoscopic surgery. What is anatomy is nothing but an anatomy is a network of fascias and planes, and finding these planes lead to bloodless surgery. So it's all about anatomy, anatomy, and nothing else but anatomy. With the advancement in technology, every time I give the lecture, the question is asked, is there a changed anatomy? Are we looking at a different anatomy? Of course not. What we have understood is that we are able to have a new perception of anatomy, and anatomy remains constant. So these are the few things all of you will have to consider: sacral promontory, fascias, spaces, vessels, and the nerves of pelvis. So anatomy is constant. Our knowledge of anatomy has changed. We are able to understand the anatomy better, and not anatomy as an anatomist, but as a surgeon who can use the knowledge of anatomy. When you are doing laparoscopy, we have a very limited vision. So what lies where, what comes next, and anticipation is based on anatomical knowledge. I have coined this word. This is called as predictive anatomy. Predict your structures before they come. And if you can get this 3D vision in your brain, then you will be able to do good surgery. So as we put the laparoscope, what are the things that we see? The most important thing that we see is the sacral promontory. All of you know that the pelvis starts from sacral promontory. Frank Nater, Gray's Anatomy, any anatomy book describes abdomen into two parts: abdominal part, which is the upper abdomen, and the pelvis. Pelvis is considered as a different thing in all anatomical books because it starts from the sacral promontory caudally. What is so great about sacral promontory? At the level of the sacral promontory, three major things happen. The most important thing is that the ureter crosses the common iliac artery from the lateral to the medial side, and it continues to remain as the medial structure. So what is the knowledge that we get? If we remain medial to the ureter, there is no question you can damage the internal iliac artery, that is for sure. Then there is a superior hypogastric plexus, and therefore the bifurcation of common iliac. The last important thing is any kind of pathology in the pelvis. You take endometriosis, large fibroids, anything, they just don't reach the sacral promontory. So whenever you are in trouble, this is the highest summit point. No pathologies reach that to that level. So you can go ahead and start your dissection wherever in trouble from the sacral promontory. As I said, these are the few things which are very, very important. The sacral promontory forms an initiation point for transperitoneal para-aortic dissection, but the common iliac artery also is there, and that is one of the reasons you have to understand the level of the sacral promontory. So this is the sacral promontory. You can see the bifurcation of the common iliac artery, which divides into the external and internal iliac artery, while the common iliac vein remains, the bifurcation is just below that. Coming to the fascias of the pelvis, these are the four fascias which all of you have to know. The fascias are the cervicovascular fascia, the endopelvic fascia, the Walder's fascia, and of course the Denon-Villiers fascia. Why is it important? The endopelvic fascia is the fascia which covers the levator ani and of course the obturator internus muscle. This is the only organ to pierce the endopelvic. The ureter is the only organ which pierces this endopelvic fascia. The most important thing is, if you do not, when you're doing a sacrocolpopexy or when you're doing a Birch repair, if you do not damage the fascias, there will not be any bleeding because all the veins lie underneath the fascia. So look at the relations of the veins to the fascia. Look at the Denon-Villiers fascia, that is the fascia between the posterior vaginal wall and the anterior wall of the rectum. Look at the cervicovascular fascia, that is the fascia which covers the anterior wall of the vagina. And of course, look at the internal iliac vein, which I have already shown you. This is also covered by the fascia. So what is the knowledge you will get from this? Remain superficial to the fascias. If you remain superficial to the fascias, you will not damage any veins. So you can see this is the Denon-Villiers fascia. If you see this Denon-Villiers fascia is the fascia, we go with this area that the fat belongs to the rectum. Well, I'll talk about it later. But if you see, remember the good old days when you put the finger here, there was bleeding because you went between the fascias and the veins. So this is very, very critical. These are the two layers of Denon-Villiers fascia, and this is very, very critical. You can see the veins of the rectum lying below the fascia and the veins of the vagina lying between the fascia and the vagina. Now, this is the cervicovesical fascia. If you remember good old days when you pushed the bladder, there was bleeding because you went between the fascia and the vagina. The veins of the vagina lie below the fascia. When you dissect the bladder, fat belongs to the bladder is very important. You can see the cervicovesical fascia, and below the cervicovesical fascia are the veins of the vagina. So what is the most important thing? Always remain above the fascia. All the veins lie below the fascia, and the uterine vessels also lie below the fascia. If these steps are followed sequentially, you will achieve bloodless and complete bloodless dissection. You can again see the implication. See, this is a robotic surgery I'm showing you. This is the cervicovesical fascia. You can see the veins underneath the cervicovesical fascia. The bladder lies anterior, the veins lie posterior. If there is these are the veins. If there is a bleeding, don't chase the veins, because if you try to chase the veins, then what will happen is that the vein will again undermine. So just coagulate the fascia and automatically the entire vein, again you can see that this is the cervicovesical fascia, this is the vein. Just coagulate the fascia and automatically the veins get coagulated. The bladder dissection, this is where you do the sharp dissection. Remain anterior to the cervicovesical fascia. Go with an idea. Fat belongs to the bladder, remain below the bladder. You can see this is the fat, just remain, because the bladder rises above the cervicovesical fascia, which is much better seen with laparoscopy than what you would do and see it with anything. Again, the Walder's fascia, this is the fascia which is behind the rectum. You can see when you want to do any kind of rectopexy, or when you want to do the dissection in endometriosis, you can see this is the Walder's fascia, which is also called as the presacral fascia. As we go down, you will see that the presacral fascia covers the presacral veins, which are the most dangerous things. And this is very, very important and significance of understanding these four fascias. The cervicovesical fascia, the Denon-Villiers fascia, again you can see these are the veins which lie below the fascia. So this is called as the holy plane of Bill-Yield, and this is the fascia nowadays with a lot of youngsters doing endometriosis and resection of the rectum. This plane is also very important for the gynecologist. You can see the fascia and the veins lying below the fascia. Now, what is more important about the fascias, other than fascias, the condensation of these fascias are also along the ligaments. So we see there are three types of ligaments which we all should know: uterosacral, the McEnrods, and of course the anterior parametrium. The uterosacral is a fibromuscular structure. The McEnrods is a fibroareolar structure, and all the veins of the vagina and all the vascular structure and the lymphatics go through the McEnrods ligament, which is very, very critical. These are the avascular spaces which are not easily seen, but they are seen when you expose the peritoneum beyond that. Why am I insisting on doing intrafacial dissection? Because fascias, if you go through any anatomical book, they lack fibroblasts. So when they do not have the fibroblasts, dissection carried out in these planes will always be avascular and there will not be adhesions. A lot of time people ask, why do we get less adhesions after laparoscopy? That is because of the presence of the fibroblasts, absence of the fibroblasts in the fascias, which is very important. Similarly, if you look, the cervicovesical fascia splits into two. These fascias are so strong that they avoid any interference from the cancer. So how do we get the spread of the cancer? The cervicovesical fascia splits into two. so as to allow the ureter, the anterior cervicovesical and the posterior cervicovesical fascia. That is the space which is very, very weak, and the cancer goes through this and spreads through this area. So this is what is the article that we published way back. All of you can go through this. It is on YouTube and also in the JMIC. So significance of the fascias: all veins lie below the fascias. The spread of the cancer is prevented by the fascias till the last stage. And the most important thing is the anterior and the posterior cervicovesical fascia allows the ureter to come in, remaining as one of the most weakest area through which all cancers spread laterally as well as into the ureter. Coming to the pelvic spaces, we know that there are 4 pelvic spaces. That is the paravesical space, the pararectal space, the rectovaginal space, and the prevesical space. When you are doing all this, if you ask me as a gynecologist, what is the space that you would like to master? I would say it would be the pararectal space. So the pararectal space is not actually a space as per as the Gray's anatomy, because space is something which is lined by the peritoneum. These are surgical spaces. So there are 2 spaces. When you open the retroperitoneum, you can go a medial approach. That is, you take the cut into the peritoneum, medial to the infundibulopelvic ligament. Once you take a cut medial to the infundibulopelvic ligament, the first structure that you will see is going to be the ureter. Then you cut the posterior leaf of the broad ligament and remain anterior to the ureter. So you cut the posterior leaf of the broad ligament and remain anterior to the ureter. This opens up the pararectal space. It is a space which is lateral to the rectum and divided by the ureter into the lateral and the medial space. Now, this is a medial approach to open the retroperitoneal space, also called as endometriotic approach. The lateral approach is when you remain lateral to the infundibulopelvic ligament and you open parallel to the infundibulopelvic ligament. So instead of going from the medial side, you go from the lateral side, and when you go from the lateral side, the first structure that you see is the external iliac artery. That is the ureter. So this is the 2 approaches that you can use for pararectal spaces. You can see the medial approach and the lateral approach. The lateral approach is called as the oncological approach. We published this way back in 2009, and now it has been validated. So this is the lateral approach for doing this. The pararectal space is divided into 2. One is the lateral space, which is called as the Latz-Go space, and the medial space called as the Okabayashi space. Most important thing for the gynecologist is to master the lateral space. That is because that's the only space where you can immediately go and clamp the uterine artery. So how do you do this? You can see when you want to open the lateral pararectal space, remain lateral and parallel to the ureter. Just remain lateral and parallel to the ureter. The only structure which will prevent you from going down is the uterine artery. Now, if you remain parallel to the uterine artery, that will open up the paravesical space. So again, to show on the left side, you can see this is the ureter. Now, once you expose the ureter, if you remain parallel and medial to the ureter, then you will see the hypogastric nerve. So that's the Okabayashi space on the screen, and on the lateral side is the Latz-Go space. So the ureter divides this space into 2, which is the lateral and the medial space. How do you open the pararectal space? Again, as I have shown you, you can see this. This is going from the medial side, the medial approach. The first structure that you would like to see is the ureter. Once you see the ureter, cut the posterior leaf of the broad ligament. And once you cut the posterior leaf of the broad ligament, then you remain parallel and lateral to the ureter. Just remain parallel and lateral to the ureter. The first structure that you see is, of course, the internal iliac artery. Continue to remain parallel and lateral. The only structure which will prevent you from going downwards is the uterine artery. And you can see the only structure that crosses this space is the uterine artery. Now you see the superior vesical artery. And if you go between the uterine artery and the superior vesical artery, you can enter the paravesical space. So you remain parallel to the uterine artery now, and push. And now you can see the paravesical space. So this is where you can best clamp the uterine artery, and this is how you can do this. When you want to expose the Okabayashi space, remain parallel and medial to the ureter. You can see the hypogastric nerve coming up over here, and then you can see that the uterine vein very clearly. So if you don't want to do this, you can see by doing nerve sparing, you just have to take the uterine vein medial to the ureter. You can see this very nicely. If you take the uterine vein medial to the ureter, the nerve automatically gets preserved. So this is the pararectal space. The next space is, of course, the rectovaginal space, where we have already insisted that fat belongs to the rectum is the right plane. So when you want to open this, fat belongs to the rectum, remain above the fat, and therefore this will be the most important thing. So you can see the rectovaginal space dissection, pull the rectum and go between the two uterosacrals. Look at the fat. Look at the fat. Initially, when we started doing this dissection, people used to say champagne effect, but it is very difficult to understand what is champagne effect. So this is a better way of understanding. Fat belongs to the rectum, remain above the fat, and then you can see this is what you can see. The two layers of denon-villus fascia. This is how you do the rectovaginal space dissection. And especially in endometriosis, this is the space which is obliterated. The most important thing, remain between the two uterosacrals. Just remain between the two uterosacrals. Remain above the fat. Give the stretch. You can see wrong plane, right plane. And this is how the entire rectovagina, this is the fat, wrong plane. This is the correct plane. Just remain above the fat. The fat is very, very nicely seen. You can see the two layers beautifully coming in. And this is the way in which you do the dissection. Now, this is the pararectal space. Again, to show you, the paravesical space is caudal to the uterine artery. And what you can do is just push everything towards the uterus, remaining parallel to this area. So we have two spaces, the lateral and the medial paravesical space. This is how you do the paravesical space dissection. Once you have seen, this is the pararectal space dissection. Once you have seen the uterine artery, now what you do is remain parallel to the uterine artery. This is on the right side, parallel to the uterine artery, and push. Parallel to the uterine artery and push. And that will open up the paravesical space. The only structure that crosses the pararectal and the paravesical space is the uterine artery and the vein. So this is the next space that we have to identify, is the prevesical space, which all of you do for various vault prolapse surgery, as well as when you want to do any kind of birch repair. The prevesical space lies between the two obliterated hypogastric arteries. So it lies between the two obliterated hypogastric arteries. And when you want to do this dissection, remain anterior to the fat, because again, fat belongs to the bladder, fat belongs to the rectum. Pull the bladder. Pull the bladder. This is the fat. Just remain above the fat. You can see that we are remaining above the fat. Let the fat go down, and this will open up the prevesical space. The key to this is to understand what is the correct area. So this is an edited film. You can see hardly a drop of blood, because we are going into the right planes. And when you do the birch repair or any kind of repairs, this is a very virgin plane. No necessity of having any bleeding if you just follow the correct planes. Now, again, to show you the bladder dissection, with this, you can see the entire uterine artery. Fat always and always is above, the bladder is above. And when you want to do this dissection, you can see remaining. So this is what you want to do when you have a cesarean section 2 or 3. Come from the lateral side, remain anterior to the uterine artery and below the fat. And this is how you can do the dissections. So this is the application of laparoscopic surgery. This is the same way. This is where you can see that the bladder is completely stuck. And now how do you use the knowledge of anatomy? We will come see, you can see this is completely stuck here after 3 cesarean section. But this anatomy will still remain the same. Just remain, push up the fat, come from the lateral side, go below, and this is slowly and steadily. Again, you can see the same thing, no change in anatomy. Fat belongs to the bladder is the dictum. You just go below the fat, just go, this is the fat. So you keep on going below the fat, and slowly and steadily you will see that you are going. So this is how you can go from underneath this area, coming from the lateral side, but following the dictums of anatomy. And this is very, very critical. This is the fat. You go below the fat, and you will see that we are now entering into the correct plane. So do not change the rules. The rules of the game remain the same. Fat belongs to the bladder, and this is very, very critical. You can see the fat. This was stuck there, just going below the fat, just going below the fat, and see how easily the bladder is going down. We are not doing anything. We are not filling up the bladder. We are just following the anatomy. And this is very, very important. Then the fourth space, this is the fourth space of Yabuki. What is the fourth space? This is a space which is medial to the ureter, and through this space, the nerve finally enters into the bladder and the lower part of the vagina. This space is only open once. You can see this is the Yabuki space. This is characterized by the presence of the uterine vein, which you can see very clearly, which comes from below the ureter, and the inferior vesical vein. You can see the bladder fibers on their way of the hypogastric nerve, on their way towards the bladder. All the fibers which are going towards the uterus have to be cut, and that is the basic knowledge of Yabuki space. So lastly, we have to understand what is parametrium. The parametrium is not as important as we are right now in the era of cancer cervix, but for endometriosis. And this is where it is important. These are the three types of parametrium. This is what I said. The supports of uterus are in a single fan shape. You can see the posterior parametrium, which is uterosacral, the lateral parametrium, which is the Macken rods, and the anterior parametrium, which is the most important thing. This parametrium is completely involved not only in cancer cervix, but also in endometriosis, which is stage 4, because the ureter is pulled medially. And understanding this is important. You can see the Yabuki space opening will allow you to go towards the anterior parametrium. So you open the Yabuki space, and once you open the Yabuki space, so this is going to be the lateral parametrium, and caudal to that is going to be the anterior parametrium. We describe this parametrium anatomically by the presence of inferior vesical vein, and this is the nerve fiber. This was not cleared in the LAC trial, and therefore it was the reason for pelvic and as well as the entire kind of metastasis. So again, to show you, to open the anterior parametrium in endometriosis, you can see you have to cut the ureteric tunnel or the area which is called as this is the cervico-vesical ligament. You cut this. You use, there are two, I always use two clips because there are superior vesical veins. And when you cut this, then slowly the ureter will get lateralized, and this will expose the anterior parametrium. So this is also in other words called as infraureteral parametrium. You can see this parametrium coming into the picture, and this is characterized by the presence of the inferior vesical vein. And this is important to understand this parametrium so that you can see this is the parametrium. You can see this is the inferior vesical vein which is going there, and this parametrium is the anterior through which all the lymphatics traverse. If you do not clear this parametrium, especially in cancer, this leads to the damage. So you can see the fibers of the hypogastric nerve going towards the bladder, and then the fibers going towards the uterus, which have to be cut so that the nerve can be further lateralized, and the nerve fibers which are going towards the bladder can be preserved. This is how you should dissect the anterior parametrium. So what about the ureteric tunnel? This is the tunnel. It's a misnomer. you catch hold of the uterine artery, and once you catch hold of the uterine artery, this is the tunnel which is going to be there. You can see, if you do not dissect that ureter, the infraureteral, this is how the ureter is completely, you can see that. Always use scissors, you can see the nerve going there. These are some things when you are doing endometriosis also very important for you to understand. So these are the key steps. And what we have learned is that this is very, very important to see and apply this in anatomical lessons. We described this anterior parametrium and won our 5th Golden Telescopic Award in 2020. And this is the anatomical description of anterior parametrium, a probable answer to pelvic recurrence following radical hysterectomy. So knowing lastly about the vessels, you can see about the vessels, the aorta, IVC, God has made these vessels for you. There are no branches, no tributaries on the anterior, the entire aorta as well as the common iliac, and it extends to the external iliac artery and the external iliac vein. The only tributary of the external iliac vein is the circumflex iliac vein, and that forms the corona mortis area. So how do you use this knowledge of anatomy? You can see this is the internal iliac vein. There are no tributaries on the anterior side, and this helps you to do the dissection by remaining parallel to the use this knowledge of anatomy, fascia covering the vein. You can do this knowledge and do the complete dissection remaining parallel to the big vessels because there are no tributaries, no branches. You can see this on the right side also. Just remain parallel, and this is how you can do this. So this knowledge is very helpful. This is just to show you one small clip. This was a node which was stuck to the external iliac vein, and we knew that it is only stuck to the medial side. There are no tributaries. As we were trying to take out the node, post-chemo, post-radiated patient, there was a bleeding from this side. So you can see the bleeding coming from there. In these circumstances, what we did was just apply the clip because we know that it is only the medial wall which is bleeding. So we use the clips completely. You can see the clips being applied. I'm just going to show you a small clip how we can use the knowledge of anatomy if we keep our cool. It is the only medial wall which is getting stretched. There are no tributaries. We know that. So we took out the node. You can see the node was completely taken out and just clips were there for the temporary purpose. And then finally what we did was we took out the clips, but we took a suture because we were very sure that there is nothing which comes, no tributaries which come from the anterior and the medial side. We could do this and tackle this. And then, of course, if you are not very confident, use this knowledge. Just use a suction catheter and you can do the pelvic lymph node dissection very, very easily. Just remain parallel and parallel to the vessels. There is a fascia which covers the vein. Remain below the fascia, and all the nodes you can take out by just using the suction catheter and nothing else but the suction, because that's how the anatomy has been made. So you see, you just go there, and you see the entire thing being exposed completely. And now you see the circumflex iliac vein coming in, which is the lateral or the caudal most limit. Do not go beyond this. This is how you can use the knowledge of anatomy. What about the internal iliac vessels? You can see that there is a long length of internal iliac vessel before the first branch, which is uterine artery, which is given. I'm not going to show you this, but you can see that the uterine artery also has about 8 to 9 branches. We showed
I'll
that
tell you one
in
thing.
live transplant,
The same
and
center
this is
where
the
this
branches
report was
we have seen.
not.
Now, what is the relation of the uterine artery to the uterine vein?
You
The
got it.
uterine artery goes
When they couldn't pick up
anteriorly.
the whole big size
Can
bio.
you mute? There's somebody who's speaking in the middle. So the uterine artery goes anterior to the ureter and the vein goes below. This is how the corona mortis will look because it is the external iliac vein tributary joining the obturator vein. The ureter, everybody talks about ureter. You see, the ureter carries its own mesentery. It is not that it is a segmental supply. It carries its own mesentery, and therefore the ureter can be completely dissected from the brim. You can see the mesentery over here. The ureter can be completely dissected because it's carrying its own mesentery. So ureter is like this. you have the artery, uterine artery above, ureter carrying its own mesentery, and the uterine vein below. So the principles of dissection: always dissect anterior to on the anterior wall of the ureter, because the mesentery lies on the medial side and ureter is always at the base of the uterosacral. So whenever you are in trouble, do the entire thing anteward the uterus and cut at the apex of the uterosacral. Contrary to the belief that the ureter is less than 2.5 centimeters away, you can see that it is more than 2.5 centimeters away from the uterus, as compared to what has been written in T-land, that at no point it is less than 1.5 centimeters. So you can see it is at the base of the uterosacral always. And therefore, I'm not going to show you this. Lastly, we'll talk about the neuroanatomy, which is important. What are the nerves that you see in the pelvis? You see the genitofemoral nerve, which is on the lateral side of the external iliac artery. Then you see the hypogastric nerve, you can see, which is always parallel on the lateral side of the rectum. It is posterolateral to the rectum and it is medial to the ureter. And then it is joined at the level of the uterine vein by S234 fibers to form the inferior hypogastric plexus. And then, of course, you have the obturator nerve, which lies between the external iliac artery and the internal iliac artery. So this is the obturator nerve. The relationship of the obturator vessels is that it is below the obturator nerve. So whenever you do the dissection, always remain anterior to the obturator nerve, because the artery and the vein lies below the nerve. This is how you use the knowledge of anatomy to do good surgery. If you see the sciatic nerve, it is quite deep down. But all of you have to remember the genitofemoral nerve, the obturator nerve, and of course the sciatic nerve, all their root value is L4-5. The sacral root is joined S234. This will join to form the sciatic nerve. So this is one area. You can see all the nerves over here, the inferior hypogastric plexus, the obturator nerve, and the genitofemoral nerve. So this is the significance of neural anatomy. Preservation of the nerve is important not only for bladder function, but also for good rectal and sexual function. And it is very important to identify. So apply your knowledge not only for benign cases, but also for malignancy. So before 2002, world was, I would say that we all knew this, but we didn't know. So you were dyslexic to how you can use this knowledge to do better oncological surgery. And now what we have achieved is functional results as compared to very good thing. So this is what we have recently published. We have surveyed about more than 500 people, and all of them in whom nerves were preserved, patients were having a good sexual function. So this is the roadmap to the pelvis. You can see the most external structure is the lateral structure is the external iliac. As you keep on coming medially, you can see the various structures, the external iliac vein, the obturator nerve, the internal iliac. Now, this is the latest paper published in 2023, renaming the avascular spaces of female pelvis. We have been quoted extensively, and all the things that I have been saying and getting published have been now vindicated. And they have said that this is what that medial approach is called as endometriosis approach, lateral approach is called as the oncological approach. And of course, all the things that I showed you, fat belongs to the rectum. You can see it is in apostrophe. For safe reason, this is what we have been quoted. So spreading all knowledge to the world, this is very important. Take home message: uterine and cervical pathologies do not reach up to the sacral promontory. So ladies and gentlemen, whenever there is a problem, start your surgeries at sacral promontory. Dissection should always remain parallel to the tubular structure. Fascias are very important. Understand the fascias. Remaining medial to the ureter will avoid damage to the internal iliac artery. Fat belongs to the rectum. Fat belongs to the bladder. Ureter lies in the fork between the artery and the vein. Ureter carries its own mesentery. But the last thing is very important. Now, I have done more than 1,000 radical hysterectomies, and I have never seen an uterine artery arising from the external iliac artery. So there are no variations in pelvic anatomy. So there is no reason, no excuse to say that I will not do and understand anatomy, because that forms the basic. What has changed? We started with radical hysterectomy in 2002. That was the first time I did my laparoscopic surgery. And we went to innovation of uterine transplant purely because of anatomy and nothing else but anatomy, which is there. So this is what Nutan was mentioning. We just did a live demonstration of uterine artery transplantation in Celsicon 2023, and we are very proud that everybody enjoyed. Thanks to my entire team. Thanks again, Bhaskar, for this complete opportunity. It is very important to understand that in the era when your armamentarium is ligashore, harmonic, 3D, what is more important is to know predictive anatomy, because good surgical precision will always come only with knowledge of anatomy. Anatomy remains constant. What has changed is perception, and all of us are very, very important to understand this. So we have to understand this, that there is compassionate courage and craziness, which is very, very important to understand this anatomy. So cornerstone is anatomy. Thank you, Bhaskar, for giving me an opportunity to speak on the topic of my biggest passion. More than uterine transplant, it's always been anatomy. Thank you so much. And thank you, Nutan and Arun Barua, for chairing the session. And of course, Dr. Trivedi, who is the pillar of this show. Thank you very much.
Thank you, sir. That was indeed from basic to executive to elaborative and to a brainstorming deliberation that we had. A legend that you are, your passion for anatomy and for laparoscopy is so very well known. Thank you, sir. We now have a chairperson to give your concluding remarks for sir's talk. Dr. Nutan Jain, Dr. Arun, sir.
Yeah, I think that's why we all know how brilliant Shailesh is. His word of predictive anatomy has percolated to the every nook and corner of the country. And every surgeon, I think, including me, I have learned tremendously after meeting him. And really, his anatomy and his thought process of teaching has evolved so many young, jubilant endoscopic surgeons in this country. Today, we are all proud of you, sir. We had you hosted in our own region. We know how busy you are, but you never said no to any academic purposes. And Bhaskar is one who has given us another opportunity to hear to your superlative talk. And your thought process has percolated down to the textbooks. And your words of wisdom, your way of looking at things beyond has really promoted the whole country to a new level and a new era. And I'm sure with today's presentation, you have added more color to your previous ones, because after demonstrating your surgery live for uterine transplant, those eyes which were thinking that it was really not up to the mark would really answer that what type of surgery you have been doing and why we all are your fans forever. And your fan club will really grow tremendously. From educative point of view, I'm sure you are penetrating too many hearts, and we are here to wish you a long life so that we students, including me and our juniors, learn more and more from your predictive anatomy and predictive way of teaching things, because that's how the science is going to grow. That's my last word to you, and I wish you live for a longer time and continue to teach, because teaching is what you love and we love too. And I must thank Bhaskar, his thought process, his way of starting things on a very auspicious day, and an opportunity given to all of us to have this platform shared for every one of you. Thank you, Shailesh.
Thank you. Thank you.
Nutan, ma'am.
Yeah, I think, excellent talk. As always, as I said, I've been listening to him in various forums, national, international, and really that's the way out, predictive anatomy. And this is what we also keep propagating amongst our students and fellows. So Shailesh, a brilliant one.
Thank you. Thank you, Nutan. Thank you, Arun. Thank you.
Definitely.
And now I see my
Definitely a new
close friend,
era.
Dr. Sanjay Patel. Hi, Sanjay bhai.
Shailesh, it's very difficult to deliver the talk after your talk.
No.
Great surgeon. You are, I told you, the best surgeon. I always followed you.
Good.
Thank you, sir. Definitely, and a new era is in the making with such legendary epic figures of laparoscopy under one banner of Endovision. And that's the vision of Bhaskar Pal, sir. We are so very proud we are all under one stream now. We now have our second keynote address by Dr. Sanjay Patel, sir. I request Dr. Arun, sir, to kindly introduce Dr. Sanjay Patel, sir.
Yeah, I'll not read this slide that has been projected because he is much more than this particular slide. Those who know him really know them well, that whether what type can, to be honest, what I feel, he can even operate blindly because his way of filling tissues with his instruments, his way of maneuvering the instruments to the different facets and different layers are simply eye-watering, and everything needs to be learned from him. And his center of excellence is, that's why it's been recognized as one of the top centers in the world to learn on the most difficult surgeries of endometriosis, which he has mastered and taught all of us. I have been with him. I have learned quite a bit from him, and I still continue to learn because Sanjay Patel is one, wherever he goes, the house is jam-packed because his way of operating is slightly different. And that is what we are here for, to learn from everybody and to do the best to the women through us, because we pick up the best things from every one of them and ultimately deliver goods to our patients. Sanjay Bhai, the floor is yours. I'm sure you will really do too good the way you've been doing in the past. All the best. The floor is yours.
Arunda, before Sanjay Bhai starts, I think apart from, we all know he's the king of endometriosis surgery. But you know, when IAG started this AGL seismic courses, an initiative essentially by Shailesh and Dr. Krishna Kumar, and identified some centers of excellence to pilot it. And when they told, we told Sanjay Bhai that you'll have to charge for it, he said, I've never charged for teaching. We said, well, this time you will have to. He's a man with a golden heart. And again, he's a very special bonds with Calcutta. Over to you, Sanjay Bhai. It's a pleasure to have you and Shailesh here today.
Thank you, Bhaskar sir, to giving me this opportunity. Thanks, Dr. Prakash Trivedi, one of the mentor for everybody. My dear friend, Dr. Nutan, and thank you very much for the kind words, Dr. Barwa. Today, my talk is related to parametrium involvement because I realized that everybody's talk related to ureteric involvement. But I realized that the most important part to understand related to parametrium involvement. And Silas is told that the predictive anatomy is very important, but in endometriosis, this is the alter anatomy. The most important part to correct the anatomy, and then you proceed for the surgery. And how you find out the plane of cleavage, how you understand the tissue of the structure. This is the most important task, particularly for the endometriosis surgery. I show you some of my cases, and this is the typically cases the entire, because ureter is the first victim. In this case, patient is presented with the severe dysmenorrhea. Previously, 4-time IVF cycle failed, wanting to hysterectomy, and at least at the last resort reduced the unbearable pain. Diagnosed unicornate uterus on the MRI, on hysteroscopy, laparoscopy diagnosed as a Roberts syndrome, severe adenomyosis extending up to the L4, L5 vertebra. Patient is present on came with the on the stature. Left hemicavity excised, adenomyotic tissue excised from the parametrium ureter, making uterus unicornuate. Patient has successfully IVF cycle and delivered the LSCS at 32 weeks due to the probe, 1.5 years after the surgery, with the good maternal and fetal outcome. And look here, this is the MRI. Entire up to the L4, L5, this is the all adenomyotic. Fibrotic band is arise from the L4 to L5 up to the parametrium and uterosacral. This is another, I think, this is the entire fibrotic band. This is the another view of the MRI. And this is also involvement of the hypogastric nerve on the one side. And look here, this is the diagram we created for the better understanding. This is, first we perform the hysteroscopy and we realize that this is the cervix. We put inside hysteroscope and this is the unicornate uterus. On the left side, we visualize the cornu. And absolutely pelvic looks like the virgin. Entire thing retroperitoneally. And the main cause is the Roberts syndrome. And look here, this is the fibrotic band. The most important part, this is what the Silas is telling. This is typically endometriotic dissection from the ureter. In endometriosis surgery, always we try to make the expose the ureter and try to make do the perpendicular to the ureter. The most important part, you understand the mesentery of the ureter, because the axis rotation of the ureter is happen in such of the cases. And look here, this is liquid collection in the entire parametrium. Again, we go for the middle parietal space dissections and try to make the identify proper adenomyotic band. And look here, this is the entire between the ureter and between the middle parietal space. This is the fibrotic band. Entire uterosacral is involved, and this is the internal iliac vein, and this is just medial to the internal iliac vein, and also lateral aspect of the internal iliac vein is also involved with this disease. So it's very important to how you dissect such kind of tissue. Rather than the en bloc dissections, debulking surgeries reduce the risk of the complications in such kind of the cases. And look here, this is the entire, this Locchino collection is work like the volcano. And always we find out the pseudo capsule, pseudocyst in the endometriosis cases. Try to make the enter in the pseudocyst and then try to make the dissecting. And look here, due to this fibrosis and the axis rotation of the ureter is happen. So mesentery will be sometimes we find out at 7 o'clock and sometime at 1 to 2 o'clock. So accordingly that you dissected. And now we enter retroperitoneally, and always the Silas is telling the water is below the breast. The one of the landmark is very important. Due to this endometriosis, the entire uterine artery is shifted medially, but one of the landmark always the water is below the breast. In this case, we ligate the uterine artery at origin. And then very important part to, I think, remove the ureteric involvement with this disease. Sometimes old school of thoughts is very important, and fiber to fiber dissection in such kind of the cases is very important. So I think this is the fibrosis of the uterine artery in these cases. We cut with the scissor. And we also do the de-roofing of the ureter. In such kind of the cases, the de-roofing of the ureter is very important, and 360-degree dissection of the ureter is also very important. You never leave the sub tissue, otherwise there is ample of chances of the recurrence in such kind of the cases. What we do in the laparoscopic work, the same way, we cut the uterine artery at origin and then we dissect. In such kind of the cases, here also you look on the medial aspect, there is some nodule parallel to the ureter, and then again we enter in the pseudocyst and we try to make the excise the entire disease. So small things is very important. I prefer to use the 1000 harmonic probe because the fine tip is one of the best for the dissections. In these cases, I think we try to make cut the round ligament, and ovarian ligament also be ligated with the ligation, and we cut it. Because in these cases, we have to have the dissect up to the ureteric tunnel properly. Otherwise, there is ample of chances of we leave the disease left behind. In these cases, the transverse parametrium is also involved, and also the anterior parametrium is also involved. So very important to understand related to endometriosis, and I think the MRI is the best tool to be picked up to parametrium involvement. We enter in the two layer of the denominator fascia. We try to make mobilize the bladder. We expose properly, and then further we dissect it more. We try to make the flush to the intrafacial, just like the intrafacial hysterectomy. We put the incisions. We split the nodules. So this is one of the things is very important to debulking surgery. Rather than the en bloc, we try to make the splitting of the nodules. It creates the more safety for the patient. So we split the nodules and then we try to make the excise over this ureter. So this is the transverse parametrium involvement. We have to have the excised properly. Again, on the posterior side, this is the posterior parametrium involvement. We dissect properly. We excise with the scissor on the anterior surface of the endometriotic tissue. The small tissue, we pick up it and we remove it. And then you palpate the ureter. This is very important. If you find out the soft filling, that means there is no muscularis involvement. This is the surround extrinsic involvement in these cases. We do the proper hemostasis under the continuous irrigation. Again, we also check related to any pressure vector over this ureter. So further, we more dissected in the ureteric tunnel. And this is the posterior surface, also the posterior parametrium involvement. But you have to have the excise this endometriotic tissue properly, because this is the fertility enhancing surgery, and there is a ample of chances of the recurrence in such kind of the cases. Again, we go for the middle parietal dissections. And this is the entire fibrotic band, approximately 2.5 centimeter to the 16 centimeter long. And this is near to the internal iliac vein. So we try to make the dissect in the, not in the end block, but we do the step-by-step debulking surgery. And we have to have the remove all the lacunae collections, because lacunae collection is create a lot of pain during the time of menstruations. So this is the posterior parametrium with the uterosacral, we remove it. And in these cases, we sacrifice the hypogastric nerve, because the entire hypogastric nerve is involved in this case. So if you preserve the one side of the hypogastric nerve, we find out in our series, I think it's not create any problem related to bladder and bowel functions. So this is the one of the take-home message we done in our institute. In such kind of the cases, we sacrifice the one side hypogastric nerve, and patient is absolutely normal related to bladder function and related to bowel functions. And this is the posterior side involvement of the disease. So this is very important. What I am telling, the 360-degree dissection of the parametrium involvement is very important in such kind of the cases. And it gives the better quality of life for the patient. And look here, this patient is 3-time IVF failed. After this surgery, patient is carry the pregnancy in the first cycle of IVF, and this is the Roberts syndrome. So we do the hemihysterectomy in these cases, because this is the one of the main source to develop the entire DI. So you have to have the excise, the what affected half of the uterus. But very important part, you have to have the remove the active endometriotic cavity gland. This is the small cavity. Still we left it. First we exercise thoroughly. And anytime you find out the stretching effect, because tissue, once the tissue, normal tissue, you get it, immediately you get the elasticity of the tissue. So once you get the elasticity of the tissue, that means this is the healthy tissue. So we excise. This is very important to, you have to have the exercise properly. And then we suture the, this is another part. On the lower side is involved with the disease. This is adenomyotic tissue. So I think the pelvis looks virgin, but look here, the involvement of this disease. So accordingly, it's just like the pesticides. ये उदय की तरह है. It's a more corrosive and infiltrating nature of this disease. And whatever you find out the macroscopically, you have to have the removed. And you consider to be first surgery as a last surgery, and it gives a wonderful outcome for the patient. I prefer to use the V-lock, number 1. And at the end, you realize that this is just like the unicornuate uterus. Because if I not remove it, then I not justified properly related to this DIE. So look here, this is such kind of the cases we prefer to do the prophylaxis degestantic. Second eye case, it's presented with the non-functioning kidney. In the renal function test is the less than 10% time. In those cases, I think we prefer to go for the nephrectomy. Even though in these cases, the parametrium involved, pelvic looks like the virgin, not much more involved. And look here, associated with the hydronephrosis, hydroureter, and presented with the non-functioning kidney. Why we removing the non-functioning kidney? Because it's create the hypertension for the patient. And second important part, I think it's further more damage to the other kidney. So it's very important whenever you find out the non-functioning kidney, better you remove it. We have the largest series. Till today, we done the 18 laparoscopic nephrectomy in cases of the endometriosis. So I think the majority people, I think, try to apply the clip and go for the nephrectomy. This is also not the right answer. You have to have the properly remove the all affected parametrium. And then you perform the nephrectomy. So one of them I take home message for the audience. I think in such cases, people is go for the direct ureteric implantation and leave the tissue, leave the disease left behind. This is considered to be crime. And this parametrium involvement associated is always with the severe dyspareunia. And this dyspareunia is the one of the main causes for the infertility. Because always it creates the puckering of the vagina and it creates severe pain during the time of intercourse. So in these cases, this is the entire ureter is victim due to this parametrium involvement. So first we excise, before we jump for the nephrectomy, first we excise the proper parametrium. We enter in the pseudocysth, we try to make the lift of the ureter and we dissect the parallel. Always Silas is telling me, try to do the dissection parallel to the tubular structure. The same manner I think we done in our institute. We dissect parallel and now we realize that it's the hourglass structure of the ureter. And on the above the level of the ureteric tunnel, the ureter is absolutely normal. So this is the ureteric tunnel, and always Silas is telling water is always below the brink. Above this level, this is the uterine artery. This is uterine artery. And ureter is always below to this one. So this is the one of the landmark. Sometimes you not identify the ureter in those cases. Try to dissect the uterine artery, and then you identify the ureter. So now we entirely remove the involvement of the parametrium. And we apply the ligation over this ureter and we complete. Another one important part, if you, I think, try to make the lift of the ureter and do parallel to the ureter, majority time your dissection is much more easy. The most important part in such cases, first you dissect sometimes we find out the two renal artery and renal vein. In those cases, always you prefer to apply the clip on the artery first and then vein. Sometimes you find out the different variants, sometimes the 3 artery, 2 artery and 3 veins, sometimes the 3 vein and 2 artery. But I think Liga clip is one of the best one. And this is the huge hydronephrosis. This is swollen kidney. Very important part, try to make the lift of the ureter and kidney. In this case, we aspirate the fluid because we're not showing this patient associated with the vaginal nodules. So we excise it and we first aspirate it and we bring the entire kidney through the vagina. Because already we open the vagina and we remove the vaginal nodules. because the lower vaginal wall is involved in this disease. We suture the vagina with the V-lock. V-lock have the less tissue reactions and it gives the uniform tension over the tissue. So I think we're extremely happy to suture vagina with the V-lock. Always do the laparoscopically because all the row surface you invert on the inside the abdomen. So there is a less chances of the formation of the granulous tissue. This is another one case. We do the renal scan and it's a more than 10% type associated. Look here, because today I show all the cases. It's the pelvic, it looks like the virgin. Look here in these cases, this is the small nodules in the parametrium involvement. But the ureter, I think it's presented with the huge hydronephrosis and hydroureter. You lift up the peritoneum, try to dissect parallel to the ureter, try to preserve the vascularity of the ureter. Silas is telling before me. And then we split the nodules. Look here. This is the vaginal involvement associated with the parametrium involvement. And this is the transverse parametrium also involved in this case. Then we dissect the middle pararectal space. And we excise it. So I think one of the take-home messages, rather than end block dissection, go for the debulking surgery, always is reduce the complications rate. This is the 2-layer of the denominator fascia. We mobilize it because lateral vaginal wall is also involved in this disease. Always you enter in the pseudo sheath and then you dissect the parallel to the ureter. In such cases, you also try to identify the uterine artery at origin. So first you create all the dissections and then you concentrate for the removal of the involved parametrium. So clear the anatomy first. This is altered anatomy, but in such endometriosis cases, you clear the anatomy first and then you proceed for the surgery. This is the uterine vein. And this is the entire disease. We remove it. Associated involvement of the lateral vaginal wall. You design your surgery such a way, so I think you have to preserve the hypogastric nerve. If the hypogastric nerve is not involved in the disease, never try to pick up the hypogastric nerve, because if you injure the nerves, the 1 mm damage of the hypogastric nerve, it's require 1 week to heal it. So this is the posterior disease involved. We excise it. So again, we apply the clip over this ureter and we cut it. I think in this fertility enhancing surgery, I still prefer to use the end-to-end anastomosis. But in those underwent go for the hysterectomy, in these cases, I prefer to do the ureteric implantations. Only one advantage with the ureteric implantations, I think there is a less chances of the stricture. Always I prefer to do the fill up the bladder and then I enter in the ridge space. I think it's very easy, even though you fill up the bladder and find out the upper margin of the bladder and then you decide. It's like the spongy layer. Always I prefer to apply ureteric implantation on the anterior surface. There is a 2 school of thought. One is related to you directly implant over this bladder and one you create the tunnel. It's make doesn't difference. But in our institute, we prefer to create the ureteric tunnel. We excise the all affected portions of the ureter. The seizure is best when you get the tactile sensation with the seizure. So you not leave the disease area left behind. I create the tunnels, put the small incisions. Also, I create the fish mouth pattern if the lumen is small. But in this case, it's the dilated lumen. So there is no need of create the fish mouth pattern of the ureter. I prefer to take the 6 o'clock stitch first. And believe me, I think ureteric end-to-end anastomosis and ureteric implantation is much more easier than the tubotimal anastomosis because it's the thick muscularis. I do the stenting first. First, I took the 6 o'clock stitch. And rest of the stitches we prepare at 3 o'clock, 9 o'clock, and the most important stitch at 12 o'clock. In these cases, we took the muscularis to mucosa, and then we hitch with the muscularis to the serosa. Look here now. This is the most important stitch. So it's avoid the unnecessary tension at the site of the anastomosis. I also prefer to apply the 2-3 more stitches, but good approximation. No need of any tight suturing. So it's one of the thoughts related to it, avoid the reflex. But I think it's doesn't difference related to its outcome, whether you directly implant or you create the tunnel. Also, I prefer to do the psoas stitch in some of the cases. So I prefer to take the 1 or 2 stitches with the psoas muscles. So one of the principle behind to this one, to avoid the unnecessary tension at the site of the anastomosis. And bladder is so friendly organ accordingly me, because accordingly me, I think the rectum and sigmoid is the worst, but ureter and bladder is much more friendly organs. This is, we create a new ostia. This is another one case, previously 4-time operator for the endometriosis, presented with the bilateral tumor mass. And this is the intrinsic ureteric involvement with the renal function test. Look here, it's less than 10%. So I think this is another case. We perform the right side nephrectomy. First, we remove the entire tumor mass. And this is the huge nodules in the parametrium. First, we excise it. We remove the tumor mass, we remove the parametrium, and then we proceed for the laparoscopic nephrectomy. We do the little bit tilt position at the time. And majority time you visualize better kidney. Then you dissect it. First, we identify the renal artery and vein. And you try to make the lift up the kidney. And once you lift up it, you realize that this is the vein. And just below to the vein is the renal artery. So first we apply on the artery and then vein. Otherwise, it's the huge loss of blood, because immediately the kidney is swollen and it's a huge loss of blood in these cases. So always dictate, you apply the clamp over renal artery first, then you lift up the ureter, because in these cases we do the reverse procedure. Previously cases we done from the below to the upward. In this cases from up to the below. And very, very easy, try to make the stress the ureter, dissect parallel to the ureter, and you look that due to the involvement of this parametrium, I think it's just like the thread. The lower ureter looks like the thread. Look here. And this is associated with the nodules. Now you look the entire length of the ureter. This is the thread-like ureter. Thank you. Thank you again, Dr. Bhaskar Pal, my dear friend, Dr. Nutan, and Dr. Arun Barua, and Dr. Trivedi to giving me this opportunity. Thank you very much, sir.
Thank you, Sanjay. A wonderful talk as always. Am I audible?
Yes, yes.
Okay. So, your cases were so excellent, and I was just echoing that Robert's uterus and adenomyomectomy, I also did just last month, and same nightmare. It was very difficult one. And just to share a very recent case, what do you feel that a lady who's just 27 years old, married for 6 months, and this parametrial endometriosis, the histopathology out of the blue came out to be adenocarcinoma, probably from the bowel. The MRI had no inkling that the sigmoid had any lesion, and it was appearing almost, as you said, a nascent, and more of the parametrial involvement going even up to the round ligament and IP ligament and all of that ureter. So we had to do, she just came back after 7, I think on the 5th day, with all the fecal peritonitis. So we had to just open her up, do a colostomy, and then refer her for chemotherapy.
I think might be this one is origin from the colon rather than this adenomyotic tissue, most probably.
Yeah, but the MRI had not shown anything at all.
Yes.
She just presented with very severe pain. All the symptomatology like parametrial endometriosis.
We observe that I think the two important part, even though whatever the parametrium involvement, the fascia is never crossed, just like the ureter. The more is the eccentric involvement, intrinsic involvement is less. In those cases, if you find out middle parametric place dissection, you find out the good plane of cleavage, and you realize that this is the entire parametrium involvement. But sometimes the hourglass structure is arise in the colon due to the extension of transverse parametrium involvement on the both the side. In those cases, the hourglass structure of the colon we find out in a couple of cases.
Yeah. And excellent though. And
thank you.
Yeah, nice cases. And just for the beginners or the mid-segment people who would like to do all these cases, we would like to just share that the use of ICG for identifying the ureters is pretty easy, not at all difficult, as all the, all gynae people who are doing endometriosis have to be their own urologists. So we must, it's good to be adept with ureteric catheters, stenting, and as Sanjay has shown, the ureteric transplantation into the bladder. So all these things come in very handy the moment we keep doing them on a day-to-day basis. Thank you once again, Sanjay. Brilliant.
Thank you.
Brilliant.
Thank you, sir. Arun sir,
Thank you, Sanjay. I think your surgical technique has been your main forefront, and your hands and your operating skill really speaks out how much volume of surgery that you really do. Whatever you do, whenever you say it is very simple, I personally feel it's not that simple for anyone and everyone. But your excellency of picking up the tissues, your ability to read the tissues with your instruments is so excellent that you can predict like predictive anatomy. And that's why you have been able to do the surgery so beautifully. And anyone who observes your surgery continuously would really fall in love with you as well, because that speaks volume of your caliber. And I'm sure all juniors, those who are willing to learn the endometriotic surgery, should follow you because you are dedicated to it. So since you are dedicated to it, instead of doing too many things for a perfection, trying to master one art has become really mandatory. I salute you. I salute you for all that you have achieved and all that you have done for us. And more so, since we know each other so closely, I too feel elated that we all are in the same boat, brother. Thank you so much for your beautiful exposition.
Thank you so much, sir. From uterine anatomy to parametrium involvement, we have been in a roller coaster ride for the last 1 hour of laparoscopic surgery, and such is the vastness of the knowledge of our legendary figures out here. We are definitely going back home with enlightenment and enrichment. Every youngster might have learned tips and tricks to detailed dissemination of information. With this, we are at the close of the first session, and I hand over to my co-moderator, Dr. Poshali Sanyal, for the further proceedings. Dr. Poshali, over to you.
Thank you, Dr. Prerna. So before I move on to the next session, which is on video demonstrations, there is a question from our delegate, sir, to Dr. Shailesh Puntambekar, sir, if he's here. Dr. Kalpana Tiwari.
Dr. Paushali will take the questions later on. Dr. Bhaskar Paul has said, as we are running out of time.
Okay, so then we move on to the video demonstration sessions, and we have four dynamic endoscopists presenting video demonstrations on complex laparoscopic surgeries. And to chair this session, may I invite our first chairperson, Dr. Manish Machave, sir. Can we have Sir's CV? So Sir is an obstetrician and gynae endoscopy surgeon from Pune, past chairperson of Ethics Medical Legal Committee of FOXI, immediate managing committee member of IAG of Doctors for Doctors by Doctors. We welcome you, sir. And we also have our second chairperson, Dr. Ravikant Gio, sir. Sir is an executive committee member, FOXI Society MOGS, Mangalore. He's the professor and unit chief, KVG Medical College, Sulia. He's the honorary secretary, IMA Sulia branch, Karnataka, 2021 to 23. Sir has published various scientific papers in national and international journals and authored chapters in OBG textbook. We welcome you, sir.
Before they start, I welcome Dr. Ravikant Godar, and I also welcome Manish. Manish is a rare blend of a medical legal expert as well as a brilliant endoscopic surgeon. And Manish, the way he got stamped as a medical legal expert, was trying very hard in the past few years to tell people that I am also a brilliant endoscopic surgeon. But I think what we've not published, and hopefully we plan to come out with it maybe by the Varanasi conference. Manish has been instrumental and led the team that developed the guideline on medical legal issues in endoscopy with a model consent form for every endoscopic procedure. And that will be put on the website, and we will have some print copies available. We are hoping to get it done by Varanasi. Over to you, Manish and Dr. Ravikant.
Thank you so much, sir. Good evening, everyone. At the outset, I have to thank Dr. Bhaskar Pal, sir, Ashish, and Subhash. When I saw the program, I got so fascinated by the program that I actually messaged Bhaskar sir and Subhash to make me a part of this program, because I wanted to attend and learn and, ask a lot of questions and get my doubts solved. So thank you for allowing me to be a part of this program, and fabulous program. Superb talks by Puntambekar sir and Patel sir, both my teachers and probably everybody's teachers. And as it is said that, when you start something, you pray to Lord Ganesha. When you want money, you pray to Lord Lakshmi. When you want education, you pray to Lord Saraswati. And when you want to do anything related to gynec endoscopy in oncology, of course you pray to Dr. Puntambekar sir, and endometriosis you pray to Dr. Patel sir. So that is how the lineage of gods in endoscopy comes for all of us. So thank you, sir, for involving me. Without much ado, this is a fantastic session on videos. May I request Dr. Damodar Rao to present a video on TLH in endometriosis and tips and tricks. I think we are running a little short of time, so I request the organizers not to read the entire CV. We know all of them are brilliant endoscopic surgeons, and they can start their presentations. That way we can have some question answers.
Thank you. At the outset, I would like to thank Bhaskar Pal sir for giving me this wonderful opportunity to speak on this platform. My talk will be on TLH in endometriosis. Is it 1 minute?
We can't see you, Damodar.
Is it seen now?
Yeah, we can see you. Yeah. Yes.
No, my talk, is it seen?
Yes.
You can see the full screen, right?
No, we see the slide.
So my talk will be TLH in endometriosis.
Yes, now. Good. Yeah.
You see it now?
Yes, Damodar. Yes. Please go ahead.
Yeah. Okay. After two great stalwarts have spoken, I guess mine will be more like a small commercial break in the main scheme of things, but I'll try and make some sense of this and hope some of you can take home some take-home points. My talk is mainly about TLH and endometriosis, and we all know what endometriosis is, and in various ways it can present. Why is it a challenge? Because of the amount of inflammation, vascularity, planning of the surgical intervention, extent of information provided to the patient, and sometimes interdisciplinary coordination is also required. both from the surgeon and the patient's point of view, the actual manifestation of the disease may be, visible to us only once we put the port inside. So proper screening of the patient, proper imaging and consent forms are very, very important. I'll directly jump into the video. It's a single video, and it's basically for a tail itch in a patient of stage 4 endometriosis. I think these are all very, very standardized steps nowadays. Basically, first thing you have to do is mobilize the sigmoid colon and then try and dissect the pararectal spaces on either side and also dissect the ureters on either side. This is the main principle of the whole surgery, but it sounds simple, but endometriosis does not present in one particular way. You can have adhesions in various formats. Here you can see that the bowel is pulled almost up to the fundus of the uterus. And usually it is only the fat that is stuck. And in this area, you can clearly go and dissect it out without much hesitation. Always have an assistant with 1 or 2 ports on the contralateral side to guide you and to separate out the structures. So once you separate the sigmoid colon, the first thing that you should look for is the ureter, and work on the medial surface of the ureter, and the space between the ureter and the rectum is the medial pararectal space. Work in this space. Once you've dissected the ureter out till a certain level, then you can work along the medial border of the lateral border of the rectum. And if you try and get into the plane between the fat and the rectum, you will be able to see that you're getting into a nice plane. So always, like Punta Maker sir says, fat belongs to the rectum. You can follow the dictum. Sometimes get a little bit into the fat and then try and stay. Nowadays, people are trying to stay to the rectum also to avoid an injury to the rectum. There's another way to look at it. Once you've done one side, I was not able to get into the pararectal space on the other side. So you go about and dissect what you can. Here you can see that it is again pulled up very, very high. And that's the right ovary that is seen over there. It was almost like a frozen pelvis, so to say. Go and make incisions wherever you can. That is the rectovaginal space being dissected out over there. And then on the right side, this is the right pararectal space, medial pararectal space being developed. So dissection of the ureters on either side is very, very important. And here, while dissecting out, I could see that this didn't look regular. What I could see was actually 2 tubular structures, right? So you could see how closely applied to the rectum it was. So dissecting the middle pararectal space on either side is very, very important. And I was just making sure that, yes, those are 2 tubular structures and that is a double ureter on the right side. So once you have something like this, try and dissect out the ureter even from the top and separate out the ureters completely as much as possible. So just again confirming that what we're seeing is a double ureter. And once that is done, I went back on the left side. So there is no, exact, there is a mathematical approach to it, but always 1 + 1 is not 2. So you have to try wherever there is some space, you got to go and get into those spaces. So here I thought I'll take the uterine artery on the left side at the origin. And once the posterior compartment is done, then you can go ahead to the anterior compartment and dissect out the bladder. Like Punta Maker sir was saying, fat belongs to the rectum and fat also belongs to the bladder. So push away all the fat, cervix, and once you can see the vertical vessels of the cervix, you're in the right plane. Not going to spend too much time here. That's the uterine artery on the specimen side on the uterus. And here you can see that the ureter was dissected and it was quite closely applied to the ovary. So that's the ovary you can see. One thing to do is get the adnexa out on both sides. Once the adnexa are out on both sides, then you can approach the uterine artery very easily. Here, the ureter was quite closely applied to the ovary and hence I changed to scissors. and removed out the ovary. It was almost coming out in piecemeal. It was all very friable tissue. And put in something from below to delineate the vault and then separate the vault. I always have a habit of opening the vault completely on one side, then going to the opposite side, and then doing the uterine artery on the opposite side, and then the vault. So the vault is completely open from anterior to posterior. And then we go on the other side, and then the uterine artery is taken on the opposite side. And that's almost the end of the procedure. So basic idea is open up the pararectal spaces and, make sure ureters are dissected out properly. It was a small rent, just a serosal rent actually, in the rectum, and with 30 Vicryl bite taken. That's the vault being closed, and just a check cystoscopy done as a completion sake. So yeah, and in the end, always do air bubble test, confirm that the rectum is intact, right? So take home points are like Sir Kuntambekar said, Sir said it's anatomy, anatomy, and anatomy. Dissect out the pararectal spaces and the ureters on both sides, and most of the times you'll be able to complete the surgery without any hitch. Thank you so much.
Thank you, Damodar. Fantastic. Just two quick questions. What is your choice of energy source, especially when you're doing a TLH in endometriosis?
I would say harmonic would be my choice of energy source because the lateral thermal spread is less. But always be careful not to touch the tip of the harmonic on the ureter, right? Because it is very, very hot. So you should be just operating just slightly away from the ureter. Do not apply the instrument on the ureter. Some of them have the habit of applying the instrument on the ureter. Don't do that.
All right. Second, very quick question, because you're doing,
And
we do so
some
much
of them also.
Yeah, we do so much of extensive dissection. Sometimes we do bowel shaving, etc. Do you follow these patients up with any post-operative investigational protocol? I'm pointing towards CRP and other acute phase reactants. Do you do that? How do you do a post-op follow-up for these patients?
Yeah, if you've done a bowel resection, anastomosis, or a shaving and things like that, usually a CRP is done. You can do the CRP on the next day. The CRP will usually be elevated, definitely be elevated on the higher side, and then you can follow up and just see that the CRP is having a falling trend. Then you can be sure that you're on the safe side. Other thing is also to look at serum albumin. They have also sometimes, look into the LFT and things like that. Like the amount of albumin can also be less, and these patients can be supplemented with some amount of albumin also.
All right. Thank you, Damodar.
Manish, I wanted to just come in with two quick points. I
Yes,
think,
sir.
harmonic is great for dissection, but I think it is, harmonic also, everything has got a lateral spread. We have personal experience that even harmonic has a lateral spread. Harmonic is brilliant for dissection, and that is why we use it. But the grade bipolar is also great. I think the only problem is because the bipolar and the monopolar is not backed by the big industry, they get all the bad publicity. So do not demean the bipolar also. I think the bipolar and harmonic, in my opinion, is a great combination. And the second thing I want to say is that apart from all investigations, what we need to take very seriously is tachycardia. In the absence of anemia, I think that anything post-operative tachycardia is something I would get really worried about. So that's the thing I insist on my juniors, that every time they go and see the patient, they see the pulse rate, and whether the pulse rate is, that is the first thing will alert me towards any complication.
Yeah, that was a very good presentation, Dr. Damodar. What do you rule out before taking a surgery? Suppose if it is a bladder involvement or ureteric involvement, how will you proceed?
Bladder or ureteric, first of all, you have to do a proper imaging and an ultrasound. If you suspect something, then you can maybe go ahead and do an MRI and see if there is I mean, you also have to look at bladder image. I mean, bladder endometriosis, probably she will also come to you with symptoms of it. Ureteric endometriosis, again on imaging, something like an MRI would give you some sort of a hint that, the ureters are also involved. Might have evidence of hydroureter, hydronephrosis. And if that is also involved, then you have to look at the functioning of the kidneys, and you have to look at the excretion of isotopes. You have to do a renal, it's a renal function test kind of thing. CT guided excretion of isotope, and you check for the amount of functioning of the kidney that is left. If it is, I think about less than 15%, you have to think of things like nephrectomy.
Thank you. Thank you.
Okay, thank you, Damodar. I think if one take-home message which comes from your and Patel sir's talk on endometriosis is somebody who's starting to do endoscopy should not venture into these surgeries initially. First, you learn, you improve your learning curve, go to a level where you are able to manage complications, and then probably start doing these kind of surgeries. So thank you, Damodar. Fantastic, nice work. May I request our next speaker, Dr. Priya Lakshmanan?
Sir, just to the organizers, just to the
Yeah.
chairpersons, sir,
Yeah.
Dr. Somil Trivedi will present his video next, and then
All
Dr.
right.
Priya will present.
All right. So we all know Dr. Somil Trivedi is a fantastic endoscopic surgeon, has been associated with so many conferences. So Somil, difficult topics, different topics, different diagnosis, different surgeries is what you're going to speak on. So Somil, stage is all yours.
Thank you. Thank you so much. Share my screen.
Surgeries for rare conditions.
Yeah.
So it's a very interesting title. So let's see.
I hope my screen is visible.
Yes, Somil. Yes.
Yeah, so I've chosen this interesting topic. Firstly, at the outset, I would like to thank Dr. Bhaskar Pal sir for giving me this opportunity on this platform, a very interesting webinar, and this interesting webinar series, the first Endovision series. So rare surgeries for rare conditions. Although all surgeries are not rare, there are some surgeries which are very common but have resulted in rare complications. So it's basically short snippets and short videos which I want to highlight through a series of videos in this situation. So this is the first case which I want to highlight. It was a simple myomectomy done for multiple fibroids, about 6 to 7 fibroids, which is the largest one about 8 centimeters and the smallest being about 2 to 3 centimeters. This patient came to us post-op on day 7. And what is interesting was she was discharged, and what you're seeing out here is this is the right side of the patient. That is the right port, which is the assistant port. And you're seeing this protrusion out here. The patient was discharged absolutely all right. She had passed motions, flatus, everything. She had eaten. But on day 7, she came with obstipation. Like she had not passed motions and was having nausea, vomiting. So we managed to conservatively, initially thinking, this is the morcellator side port, if you're seeing, which is absolutely normal and healthy. And to our surprise, this is the picture which is actually of a 5 millimeter port. But if you see, if the 5 millimeter port is also manhandled or mishandled, you see how much the defect is out here. That is actually my finger, which you're seeing inside, and the bowel is completely herniated. And so we managed conservatively thinking it is subacute bowel obstruction, but that did not give respite. And so we went for a relook laparoscopy. Fortunately, the bowel had not got strangulated. And that time we had a very enthusiastic, like sometimes it's good to have lean assistants. We had a nice bodybuilder kind of an assistant, I would say. So sometimes we also make a loose remark, like, kya nashta nahi karke hai? So sometimes it's good to have a nice, subtle or subtle assistant who does his job very carefully and subtly. So what is important and what is the take-home message out here is that in myomectomy, it's not the traction which is very important. It's the counter traction that is more important. So it's important not to give undue traction on the myoma screw. And always, 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 despite that you feel that, like a 5 port, like always remove your secondary trocars under vision. And sometimes, even though it might appear small, it can have a big facial defect, not a peritoneal defect, but it can have a big facial defect. So close your fascia properly. Now, coming to the second case, again, this is an interesting case for which, prior to the morcellation controversy, the hysterectomy was done by us itself. And the patient had undergone a lateral coring technique, which we do left, right, and center 9 years back. And the patient presented to us with vaginal nodule. This was a cystoscopy, which was showing a bulge protruding into the bladder. And because of the lateral coring technique, this was a hysterectomy for which the hysterectomy was done for multiple fibroids again. And due to the lateral coring technique, again, if you're seeing out here, this was a case of vaginal walled fibroids. The the vesicovaginal plane out here is being dissected. And what you're seeing out here is the fibroids, which have grown again in the vesicovaginal plane and in the vaginal walled area. Now, this is interesting because there were various differential diagnoses which were suspected. Some suspected stump carcinoma, some suspected tuberculosis also, some suspected rectovaginal endometriosis, which post-hysterectomy is very popular and obviously, like diagnosed nowadays. And again, this is like a tip of the iceberg phenomenon like in endometriosis, wherein even though we were perceiving or feeling only one nodule, slowly and steadily as we dissected more and more, multiple fibroids came out. And since the vaginal vault was already open, the retrieval was not a problem at all. This highlights again another important point, that even if we are doing vaginal retrieval of specimen, I think it is preferable that that also should be done with a containment system. If you see the post-op cystoscopy, the bulge has disappeared and the ureteric jets were beautifully seen. Now, this again highlighting a very beautiful case. And this was confusing because it is very tricky whether this is diffuse leiomyomatosis or some malignancy. The interesting part about this female is that this is an unmarried 18-year-old girl who has never ever been operated and had come with a CT report suggestive of multiple studded sub-centimeter to 2 centimeter lymph nodes. And she was worried whether it would be cancer. So we went in with the scope, thinking that probably we'll at least have a look. It was reported to have some, like 3 to 4 centimeter adnexal mass. So here what we are doing is we've injected some amount of dilute vasopressin and we are taking this peritoneal, like how we do in endometriosis. If we are having a bunched up, like DIE kind of a focus, then we dissect that entire peritoneal area. So entire bunched up conglomerated part of the fibroids are being dissected and just sampled out. So if you see out here, the entire anterior peritoneum, the uterus, if you see the bowel, that's the sigmoid, the anterior abdominal wall, entire peritoneal cavity is virtually studded with fibroids, And at that moment of time, to be very honest, we didn't know whether these are fibroids or something else. That's the omentum. So this patient nearly had about, I wouldn't exaggerate, like if we sat counting, probably 300 to 400 fibroids. That's the omentum again, which is completely studded, like even the hepatic area, if we take the scope up, it's completely studded. So we were limited in our options because you cannot, like excise or do a radical surgery in this because this patient has never had a surgery prior to this. And you see the leash of vessels out there. It's deriving obviously aberrant vasculature from here and there. And we had to get a histological confirmation, which then later did actually turn out to be leiomyoma only. So this patient was then put on medical management, and fortunately, she didn't have any occlusive symptoms, and the fibroids, as you saw, were not that big in size. But what I want to highlight through this video is that leiomyomatosis peritoni, and what you will see now out here, that is parasitic fibroids or something that happens iatrogenically. Now, post-morcellation, the fibroids which we call the parasitic fibroids. Now, these are very defined fibroids. So leiomyomatosis peritoni disseminata or leiomyomatosis peritoni and these parasitic fibroids, please understand, are two different entities altogether. They are not the same. Iatrogenic fibroids also do, get their vascularity and everything aberrantly from here and there, that is from the omentum. This also is a complicated surgery. But if you see the nature of the leiomyomatosis peritoni and the nature of parasitic fibroids, it's completely different. So this is not the uterus. This is a large fibroid sitting near the rectal area in the pelvis. That's the ureter. So we are going ahead dissecting out the retroperitoneum, identifying the ureter, and safeguarding the ureter, identifying the ureter out there, and safeguarding and taking these fibroids out one by one. Now, this situation obviously is a nightmare situation. So I still don't understand, why we are living in a dilemma or debating that or doubting the role of containment systems, be it any sort of retrieval. I think Dr. Machwe sir is morcellating. Had once chaired one of my sessions, and he had said a 5 centimeter fibroid I can very well retrieve, without any dissemination of fragments. I totally agree, but what we don't see is cellular spillage. So Dr. Machwe and anybody in the audience, I totally agree with your sentiment that macroscopic dissemination may not be visible or may not be evident, but we cannot control microscopic dissemination. And even for parasitic leiomyoma to develop, there has to be some tendencies in the patient. And leiomyomatosis peritoni, as I said, can be a completely de novo entity altogether. Now, coming to this video, I would say this is a lucky escape. This is a prolapse surgery which I was doing. And, everything is finished. This is a sacrocolpopexy, sacrocolposuspension in a vault prolapse. And this is the last step, wherein we are just closing the peritoneum. And you feel ki chalo, everything is over and quickly we'll now, go for lunch or something like that. And at the last step, the needle just wobbles out here. And what happens here is because of the pneumoperitoneum, the left common iliac vein is usually compressed because of the pneumoperitoneum. So what has happened out here is that the needle has actually punctured the left common iliac vein. And at this situation, there are only two things work. One is prayers and one is pressure. So what we are doing out here is applying a lot of pressure. At this time, Dr. Sailesh Puntambekar sir gave a talk today. Dr. Sanjay Patel sir gave a talk today. At this time, you think of all your mentors and gurus. I, in fact, intraoperatively called Dr. Deepak Limbashya sir during this case and, asked him ki what is supposed to be done. He told me, take a stitch. I was like, one bite of needle has caused this. I will try apply pressure. So I was worried, if I take more bites, it might cause more trouble. Fortunately, as I said, with sustained pressure and continuous prayer, after 20 minutes of applying pressure, this had stabilized. And fortunately, the vitals of the patient throughout this entire 20 minutes of this maneuver were continuously stable. We did give 2 PCV to the patient, but the patient recovered perfectly fine and was discharged on day 3 post-surgery, just due to observation. Sorry for that. This is the last video. I'll take about a minute more. So this is another complication that we see. This was a sacrohysteropexy, which I had done, conserving the uterus. For a nulliparous prolapse, and this uterus was this was a grade 3 prolapse, and she had this mesh which was fixated, and she was complaining of a lot of backache. And as you saw the MRI picture, it was suggestive of lumbosacral discitis. Actually, recently we attended the Urogynec conference in Ahmedabad, and I picked up a very good point from Dr. Pandit Palaskar sir, our IIG president, wherein he prefers to fix the mesh, that is this mesh, not at the promontory, but below it. So that is another thing which can be as a take-home message, that rather than fixating the mesh at the sacral promontory, you can target fixing it slightly below the sacral promontory. This can be a nightmarish surgery, as you can see all the cleavage planes because of the mesh and the fibrosis, and the pus material is completely like gone, and it's a very difficult surgery because of the fibrosis, and you have to be very steady, and you have to excise this mesh, because without excising it serves as a nidus of this infection. And you remove this mesh and put the patient on antibiotic coverage, and remove this mesh completely. And another thing, rather than using the metallic tackers, it is preferential that you can promonto fix it using the ethibond sutures. So that was another take-home message, that instead of using the promonto fixation tackers, that is the metallic tackers, it is better to use the ethibond sutures. At the end, I apologize for this, but I would be happy and obliged if you can solicit your support for the upcoming IIG elections. I thank Dr. Bhaskar sir and the conveners of this program for giving me the opportunity to share on this topic, that is rare surgeries and rare conditions and rare complications. Thank you so much.
Thank you, Somil. Really rare surgeries and really nicely presented. Very nice cases handled. 2-3 points. One is I completely agree. Leiomyomatosis disseminata peritoni is a different thing. It occurs as a primary. It can occur as a primary pathology in the peritoneum, because we know that peritoneum has pluripotent cells, which can, in accordance with whatever circumstances are there, they can grow into different types of tumors and cells. That is where primary ovarian carcinoma also comes up. Point of content morcellation, I completely agree. Yes. So in today's era, I think we should be using content morcellation. The only issue is when you are actually dissecting the myoma after taking an incision, at that point in time also there could be some microscopic cells falling down. So, but content morcellation, I don't think there's a debate anymore. We were debating it long back, so there's no debate anymore about that. But fantastic cases.
As a medical legal expert, I think, like it's better to be safe than sorry. Like,
yeah,
I think that is,
agree.
I mean, you being the medical legal expert, I think that is the principle we should follow.
Yes. And again, about the vessel injury which you showed, I have faced it when I was putting a primary trocar and hit the sacral promontory. Now, I did not know what was bleeding inside, but trust me, a continuous pressure of with a gauze piece of giving 15-20 minutes of pressure actually stopped the bleeding. So thank you, Somil. Nice presentation.
Somil, I have a question for you.
Yes, sir.
I have seen in a Dr. Shailesh Puntambekar demonstrate an external iliac vein injury when Surgical snow first came in.
Yes,
the pressure with the Surgical snow. So did you consider that, or you didn't have that at that moment?
I didn't have the surgical,
Okay.
but I've seen it being used, sir.
I think if you have the Surgical snow,
Yes,
to put the Surgical snow and then put the pressure, it will be much quicker than 20 minutes. That's a savior.
It was, I mean, it's the first time I encountered a very bad major vessel injury. So literally it was a heart in the mouth, or probably some other organ in the mouth situation. So
It was a very nice.
So good take home, Somil, would be that, everybody who's doing endoscopy, in fact, anybody who's doing any kind of surgery should always have vascular clamps ready in the OT and where you can find them. So I have found vascular clamps in OT at odd places where people also don't know where they have kept it and how to find them. So vascular clamps available in OT readily is, I think, a must.
Yes, sir.
Yeah, your presentation of all rare cases shows that the volume of cases your people are exposed.
Thank you,
and
sir.
You mentioned that even the second report removing also should be under vision.
Of course.
Especially following myomectomy, when we handling or suturing also, definitely even 5 port also may get enlarged little more weakness was possible. So even that was a very good valid point. And leiomyomatosis also like a very rare condition, and many people may not be seen it, must have read in the textbook. So you got to see that patients and could handle also. And one more thing, what is the mesh you mentioned? Mesh infection was there. It was done for a prolapse patient. So and all the mesh was removed and patient was all right. Now, what about that prolapse condition later? What was done for her?
Because of the fibrosis and everything, it was still minimally rectified. So it was not like totally out and overhanging. So we just removed it. Obviously, there was a little bit of sagging, but it was not completely like how it was before.
It was a very nice presentation. Thank you.
Thank you. Thank you.
Thank you, Somil. The next presenter is Dr. Priya Lakshmanan. She's going to talk about laparoscopic birch colposuspension. And in this era where, US FDA and a lot of people are opposing using the transvaginal tapes, etc., so TVTO, etc., laparoscopic birch remains a very good option. So, Dr. Priya, stage is yours.
Yeah, thank you. Thank you so much, Manish sir. On the outset, I would like to thank Dr. Bhaskar Pal sir for involving me in this webinar on Endovision. And the topic given to me is Birch colposuspension. Can you allow me to share my slide? Yeah. Is my slide visible?
Yes, it is visible.
Yes.
So we can very well see from this slide that the stress which is experienced by a patient who's had a stress urinary incontinence, and most of the patients with stress urinary incontinence learn to live with the problem. So that is why in my gynecopedia, I always have a questionnaire asking for stress on patients, because most of the patients don't come out with the symptoms. And when such stress urinary incontinence persists despite of non-surgical treatment, surgery is often recommended. And the surgical options available for stress urinary incontinence are open abdominal retropubic urethropexy, that we call it as a Birch colposuspension. And we have laparoscopic Birch colposuspension, anterior colporaphy, where we take a Kelly's plication. We have suburethral slings like TVTs and TOTs. Needle suspensions like STAMIs, periurethral injections, and artificial sphincters are all available for management of stress urinary incontinence. So the Birch was first described by Dr. John C. Birch in 1961, where he attached the paravaginal fascias onto the arcus tenuis fascia, and later on this site of fixation was shifted to the Cooper's ligament. And it was Tenango in 1978 who modified it to the current status, where the paravaginal sutures are taken way lateral to the urethra and they're loosely attached to the Cooper's ligament. And Birch is specially addressed for stress urinary incontinence, secondary to urethral hypermobility, and it does not take care of stress urinary incontinence, secondary to intrinsic sphincter deficit. But in the following years, when the vaginal mesh gained popularity, the usage of Birch really came down. And as Manish sir was saying, in 2019, when the Food and Drug Administration forbidden the use of transvaginal meshes, I think more and more gynecologists are resorting to this old age procedure, that is the Birch colposuspension. So for diagnosing stress urinary incontinence, when the patient is asked to cough or sneeze, when she demonstrates enormous amount of leak, and when she has a normal urine analysis, and when the post-voidal residual urine is less than 50 to 100 ml, we can make a diagnosis of stress urinary incontinence. And there are other tests like the stress pad test, the Q-tip test, the Boney's test, and we also have the transperineal ultrasound to see for the urethral hypermobility. And urodynamic study is generally not used for patients to diagnose who are suffering, especially with stress urinary incontinence. It is only reserved for patients who are having a mixed incontinence in order to differentiate a stress from the urge urinary incontinence. And how does the Birch mechanism acts? It restores the anatomical support of the bladder neck and thereby preventing urethral hypermobility with the wells, which is well demonstrated with the Valsalva maneuver before and after the Birch procedure. It also lifts and supports the uretrovesical junction, thus increasing the bladder outlet resistance. And the classical indications of Birch are you can resort this Birch colposuspension to all patients who are suffering from stress urinary incontinence secondary to urethral hypomobility. But we choose Birch for especially for patients who are having aversion towards mesh and who wants to undergo a concurrent abdominal approach surgeries, like we combine it with the total lap hysterectomy or myomectomy and so on. And when cost is a constraint, because Birch is relatively cheaper when compared to the TOTs. And coming to the procedure, The first thing is the bladder is filled with 200 to 300 cc of normal saline. And then we make a transverse incision around 2 centimeter above the dome of the bladder, trying to stay in between the two medial umbilical ligament, because moving lateral to the medial umbilical ligament, there are likely chances that you'll injure the inferior hypogastric vessels. So this is called the cotton candy space, because it's a total avascular space when you're in the right plane of cleavage. And we try to stay between the bladder and the anterior abdominal wall, and the dissection is carried down until we identify the pubic bone, the pubic rami and the pubic symphysis. So once the pubic bones are identified, the bladder is completely emptied, because as we follow the dissection more down, there are likely chances that we might injure the bladder if it is completely filled. And the next step is we expose the obturator muscle and the arcus tendinous fascia, or the white line. So this is done on the right side, and we follow the same dissection on the left-hand side to expose the obturator muscle and the arcus tendinous fascia. So once identifying all the structure, the next thing is to identify the paravaginal fascia, that is the pubovesicocervical fascia. So in order to identify the paravaginal fascia, the surgeon himself elevates the vagina using the index finger, and then we medialize all the fat towards the bladder. So the white glistening structure, what we are able to see is the paravaginal tissues, and the first suture material, using an ethibond suture material, we take the first bite on the mid-urethra, and which is tied very loosely onto the Cooper's ligament. And the second suture, which is taken at the bladder neck, and which is also loosely tightened to the Cooper's ligament. So since this is a sling procedure, the suturing should not be tightened. So we just make a sling suturing, connecting the paravaginal tissues onto the Cooper's ligament. So there are a lot of trials which have come out using a single suture or a double suture. They've found that the efficacy of Bursch-Kolper suspension is better with taking two sutures rather than one suture, with a cure rate of 84% with the two sutures, and around 45% with the single sutures. And there are certain surgeons who also prefer to use meshes and tackers in order to do a Bursch-Kolper suspension. And studies have proven that suture materials are superior when compared to the meshes and the tackers. So once this is done, a complete hemostasis is achieved, and the parietal peritoneum is closed using Vicryl. And this is a schematic, illustrative picture of how a Bursch-Kolper suspension is done. You can see the surgeon elevating the vagina, and the needle is drive through paravaginal tissue, avoiding the full thickness of the vaginal wall, so that the suture material does not get exposed in the vagina. And one is able to identify the two sutures which are taken in the paravaginal tissue. One is at the level of mid-urethra, and how we identify is this with the Foley catheter inside. Palpating the Foley catheter, we take the suture in the mid-urethra, and palpating the Foley bulb, we take the second bite in the bladder neck. And coming to the complications of Bursch, there are case reports of hematoma and transfusion events in 2% of patients. Bladder injury reported as high as 9.6%. There are incidences of urethral kinking, though it's very rare, up to 2%. Postoperative complications such as urinary tract infection, which I have also encountered in many of my patients. Wound infections around 4% to 10.8%. And there are case reports of de novo dextrosa overactivity post Bursch-Kolper suspension, and delayed presentation of suture material getting eroded in Bursch-Kolper suspension. These are especially when they used meshes for Bursch-Kolper suspension. And this is one point, like when I was trying to take the sutures through the Cooper's ligament, I have encountered few incidences of hematoma formation. These are because of the small arterial branches which are found on the superior rami of the pubic bone, and this was identified as the arterial corona mortis. That is, it is the vascular communication between the inferior epigastric artery and the obturator artery, which forms the arterial corona mortis. And this is one such incidence when I was trying to take the bite through the Cooper's ligament. I accidentally punctured the vessel, and you can see the amount of hematoma which has formed immediately, and I had to use a bipolar and a sponge to control the bleeding. And once this is done, using an ultrasonic scalpel, I'll try to expose the pubic rami and the ligaments well. So after obtaining a hemostasis, you can see the bone is exposed well and the ligament is also exposed well. And then I have taken the suture in the Cooper's ligament. And this is also another case where I encountered bleeding while I was dissecting at this plane. And the same thing. So using a bipolar cautery, I try to achieve the hemostasis. And I had to complete the procedure. And I have also encountered one case of suprapubic abscess following Bursch-Colpo suspension, where I had managed it conservatively by using an ultrasound-guided needle aspiration of the pelvic abscess. And I've done the aspiration twice and put her on high-dose antibiotic where she resolved completely. And there are also case reports of post-operative suprapubic abscesses in post-Bursch-Colpo suspensions, which have been reported. And with all this, I would like to conclude that nowadays tension-free midurethral slings have replaced Bursch-Colpo suspension due to its easy application, minimally invasiveness, less hospital stay, low recurrence rate in a 10 years follow-up period, and it also contributes to the correction of the sphincter impairment, unlike the other surgeries. So tension-free midurethral slings have become the first line of choice. But in view of the current debate regarding the mesh-related complications, there is need to readdress on Bursch-Colpo suspension for treating a stress urinary incontinence. And with all this, I would like to thank Dr. Bhaskar Pal sir, Dr. Manish Machave, and Dr. Ravikant sir for this wonderful opportunity given to me. Thank you so much.
Yes, that was a very wonderful presentation, Dr. Priya.
Thank you, sir.
Yeah, like a TVT and TOT and even Bursch-Colpo suspension are having equal results. So when do you prefer Bursch-Colpo suspension when compared to midurethral slings?
We do a lot of TOT, I mean, trans-operator tapes. But the thing is, when I examine the patient in the OPD, when I feel she's got more amount of stress urinary incontinence, when she coughs and sneezes, if she produces enormous amount of urinary incontinence, I would rather prefer to go in for a transvaginal tape than the Bursch-Colpo suspension. But Bursch-Colpo suspension I prefer when I am doing a concomitant abdominal surgeries. If in case I am doing a hysterectomy or a concomitant myomectomy, when I'm intra-abdominal, I go for it. And certain patients are really, they say no to meshes. So in those kind of patients, I go for TVT. I mean, the Bursch-Colpo suspensions.
Yeah, you just have to
Priya,
remind us. There is a
nice presentation, Priya. Two comments. One is about the bleeding that you showed. At the lateral border of bladder, there is always a constant vein which is quite big and visible. So
No, that is the
try and look
operator
for it.
vessels. I have not
Yeah.
gone so much posterior because these vessels I have found it just on the posterior aspect of the pubic rami. So when I went through the literature, I came to know that they are the corona mortis arterial communication between the inferior epigastric artery and the obturator artery.
Obturator artery. Okay.
That is
So
what we need to just
nicely
coagulate
managed.
those vessels and then
Yes.
take a suture so
Suture.
that you don't encounter this.
Second important thing is also when you examine the patient, it's very important even in today's era where urodynamic testing is available to do a simple Boney's test. So if Boney's test shows that there is urethral hypermobility and your two fingers when you're putting paravaginally and lifting the urethra and the stress incontinence gets corrected, that those are the patients where birth is going to work. So of course you rule out urgency incontinence first, but doing a Boney's test, I think in today's era very important. One quick question for you: do you do cystoscopy after all Birch Colpo suspensions?
No, I don't do it because I think the planes are very clear and I don't do it.
Okay.
Because we medialize the fat towards the bladder and we observe the white glistening vagina and then take the suture. So I don't think it is always needed because we are at the level of bladder neck, not above that.
All right. Okay. I generally prefer to do a cystoscopy, put in a histoscope, just see from inside the bladder that all the walls are okay and you have not passed the suture anywhere in the bladder. And if you have, your scope is still in, you can remove the suture and reinsert. So, and keep the catheter for a longer time. So it just becomes a little easy. Okay.
Yeah,
Thank you.
like a vascular injury, if any bladder injury, if we encounter during doing a Birch Colpo suspension, do we go ahead doing that, or I want to?
It's the same way, like how we repair the other bladder injuries, we go ahead with repairing the bladder injuries and keep the catheter in situ.
In the same setting, you want to go ahead.
The same setting.
Yeah. Yes, sir. You just remove the suture. If the suture has gone, you remove the suture, and now you have the cystoscope inside. So you put the suture under vision, or you confirm that the next suture is not gone. Complete your surgery. Keep the catheter for a little longer time, and that's it. You don't even have to do anything for suturing.
Dr. Manish, can I add something in this?
Yes, Farendra, please.
Yes. See, as far as this Birch is concerned and mid-urethral instability, for that mid-urethral instability, your Kelly's, TVT and TOT are the first surgeries. For your bladder neck instability, Birch is a preferred one. See, these are two very different things. Intrinsic sphincter deficiency, madam has already said. So don't take Birch as a primary one. See, you have got a Kelly state, paraurethral plication. People are putting a vaginally small mesh just below the urethra and the patient is getting benefited.
Correct.
So Boney's test is very important for mid-urethral instability and the procedure are different. Thank you.
Yeah. Thank you, Farendra. Correct. I just wanted to bring in the fact that even in today's era of urodynamic testing, your clinical examination still holds a lot of value.
It's very important. It's very important.
Thank you. So thank you, Priya. Fantastic talk. Very nice video. And you showed your complications also. Thank you so much.
Thank you.
Priya, sir.
Next, we have Dr. Mukta Agarwal. Has she joined? She's going to talk about she's going to talk about a very important subject where a topic which urologists used to do, and people used to say that we feed the urologists with so much of these surgeries, and now we all are doing these surgeries on our own. So I think थोड़ा urologist से कुछ सामान हमने भी चुरा लिया है. खैर हमारा अपना ही था, तो उनको देने की कुछ जरूरत नहीं थी. So she's going to talk about ureteric reimplantation. Dr. Mukta, stage is all yours.
Yeah, before Mukta, I just want to come in before Mukta starts. I think this is an 8-part series, and I'm sure that we'll be able to provide an opportunity to every young endoscopist in the country, young and not so young, to showcase their talents. That's number one. But I also want to go on record that 6 people on this webinar faculty today, I have had the privilege of having them as managing committee members when I was the president of IAG. And all 6 of them have been brilliant workers, while Subhash Malya, Somil Trivedi, and Manish have been vocal workers. Damodar Rao, Priya Lakshman, and Mukta have been very silent workers. So I think it's a privilege to have all 6 of you here. And the stage is yours, Mukta.
Thank you, sir. Thank you for everything, Bhaskar sir. And with the permission of chairpersons, I would like to share my screen. So, is it visible?
Yes, yes, please start.
Thank you, sir. So I'm going to speak on ureteric reimplantation. So the incidence of ureteric injuries are 1 to 2% in our gynecological surgeries. And if intraoperative these are diagnosed, then better to manage intraoperatively. So here we present a case of a multiparous woman who had undergone a surgery, total abdominal hysterectomy 2 months back, with complaints of continuous dribbling of urine after 2 months after the surgery, and in CT urography. So this is the CT urography sagittal view, and these are the rendering images. And images were showing left-sided hydroureter with contrast leakage through the communication, and there is a gap of almost 5 centimeter. So on putting the scope in, we used the standard central port, 2 left-sided and 1 right-sided port. There were omental adhesions on the vault, which were removed. And then we could visualize the vault. And after that, we went for dissection of the left-sided ureter. We opened the retroperitoneum and ureteric dissection was done. Since this was a hydroureter, because of the obstruction at the lower end, so the identification of ureter usually is not difficult in these cases. So ureter should be thoroughly mobilized throughout its length. Till we reached at the lower end, and the lower end was buried somewhere in the adhesions. After dissecting the ureter in whole of the length, then we went to dissect the bladder, and bladder was partially filled, and dissection was done in the space of Retzius. So, as shown by the Sanjay Patel sir in his very nice video too, the space of Retzius was dissected from one median umbilical ligament to the other medial umbilical ligament, and this dissection should be very thorough so that bladder could be mobilized, because here we have a gap of 5 centimeter between the lower end of the ureter and the bladder. So adequate mobilization of bladder and the ureter will further prevent any undue tension on the ureter post reimplantation. In this case, we sacrifice the median umbilical ligament too for adequate mobilization of bladder. And by adequate mobilization, we could actually pull the bladder to at least 5 centimeter up. After adequate mobilization of the bladder was hitched to the psoas muscle with the help of 3 interrupted suture with vicryl number 1. After this bladder mobilization, the lower end of the ureter is freshened up. A 6 French DJ stent is then introduced in the ureter, and then a cystotomy is made on the anterolateral aspect of the bladder. And the other end of the DJ stent was put through this cystotomy, and the ureter was anchored to the bladder mucosa with 4 stitches. The first stitch was taken at 6 o'clock position. And the subsequent stitches were taken at 3 o'clock, 9 o'clock, and 12 o'clock position respectively. After completing uretrovesical anastomosis, the muscularis layer was further stitched to give a sphincter-like action and to prevent any amount of vesico-ureteric reflux post-procedure. After finishing the procedure, we did a cystoscopy and we get the reflux on both the sides, and DJ stent was kept for 6 weeks, and post 6 weeks it was removed and a cystoscopy was done. Thank you.
Thank you, Dr. Mukta. Nicely done. One or two quick questions. Why did you, it appeared that you used barbed suture for ureteric reimplantation?
Yes, sir.
So you could have taken continuous sutures. Why you kept on taking interrupted sutures? So you start with 6 o'clock. The trick is you start with 6 o'clock, go inside out, outside in.
Outside in, and then you can
hold the suture, then put the DJ stent so that the suture goes below the DJ stent. Then put the stent in the bladder, and then just continuously you can take 2-3 sutures, go starting from 6 o'clock, going to 9 o'clock, 12 o'clock, 3 o'clock, 3 sutures, and then you can pull it and you can cut. That's good enough.
Yes, but that time we were just afraid that if it were giving any amount of ureteric stricture later on or narrowing, if we put a continuous kind of suture.
What is the, like, is there any advantage of doing a tunneling to prevent the reflex?
Sir, as Sanjay Patel sir said, sir has a vast experience that practically it does not have any effect, but yes, theoretically tunneling helps, because when we oppose the muscularis layer over our uretrovesical anastomosis, so it gives some amount of sphincter-like action.
Yeah.
But
okay, why did you do cystoscopy immediately after reimplantation? You have put the ureteric stent, it is in place. Cystoscopy is not going to give any advantage at that.
Maybe, but it was our very first case. So we did cystoscopy for that.
One last question. How many days Foley's catheter? Because you have done cystotomy. So how many days Foley's catheter?
Foley's were kept for 14 days in this case.
All right. Okay. Thank you so much. Fantastic surgery. Nicely done. Nicely demonstrated.
One question, sir.
Yes, sir.
Just to prevent stenosis in the postoperative period, what are the precautions you would suggest?
Sir, one is we used to keep the DJ stent, which will prevent stenosis. Second is most important, what I feel is that there should not be undue tension over the ureter. And then in all our cases, because we are not doing this very frequently, we go for post-op CT urography after 6 weeks to rule out any amount of stricture or stenosis.
Okay, thank you.
Another good pickup point is that, avoid any urinary infection. So you have to tell the patient to drink a lot of water. Urinary relaxants at times help because there are spasms sometimes the patient faces. And very important is to give them urinary alkalizers, etc. So prevent urinary infection is the one very important point whenever you have done a ureteric reimplantation.
Yes, we give alkalizer, and as well I give nitrofurantoin OD dose just as a in a form of urinary antiseptic for 14 days. Catheter.
One last question to Manish sir only. Sir, what is the medico-legal implication of it?
Nothing, sir.
If any
Nothing, sir. Don't worry. In case there is any, you have my number. So don't worry. There is none. There is none. So, but I'll tell you. I'll tell you
Sir,
what I
for you,
do.
there is none. But for us, there are a lot of problems, sir. So please guide us.
No, Subhash, so I'll tell you a shortcut. This is what I follow and this is what I tell, because I always preach, whatever I practice. Whenever we are doing any surgery on the bowel, whenever we are doing any surgery on the ureter, whenever we are doing any surgery on the bladder, just make it a point that one of your urologists or GI surgeon friends puts notes on the paper that he or she was there or assisted or you have consulted. Now imagine, even Patel sir, he also openly says his assistant is Dr. Lakshman Khiria, who is a renowned GI surgeon. So when he is doing all those surgeries, he is assisted by presence in the OT of Lakshman Khiria sir. So, it's a very good thing to do. So please do that whenever you are contemplating this surgery. That is only one take home for all of us.
Actually, there is a problem being in tertiary care center. Urologists, they do not allow us to do these procedures. I really have to struggle with them for doing ureteric reimplantation and those
मैडम,
kind of
आपने उनका ब्रेड बटर नहीं, आपने उनका चिकन छीन लिया तो कैसे बोलेंगे ना वो? आपने उनका चिकन ही छीन लिया है, ब्रेड बटर तो दूर की बात है. But
I
anyway,
really had a tough time.
yeah, so you have a team. That is how it works. I also work in a corporate hospital. You talk to them, you have a good team ready, and then it works out. Eventually, it will work out. Don't worry.
Yes, sir.
So thank you so much, Srikant sir. Any closing remarks? I want to thank Bhaskar sir, Subhash, Ashish, and everybody for allowing me to be a part of this session actively. And I actually asked them to make me a part. Fantastic session, superb talks, sahi videos, learnt a lot. Srikant sir, over to you.
Thank you, sir. Thanks. Same here, sir. It was a wonderful presentation, and all rare cases we could able to see, and like very renowned approaches were also there. So it was very wonderful. Thank you, Bhaskar Pal sir and Dr. Subhash Mali also. Thank you everyone for this wonderful opportunity.
Thank you, sir. Thank you, sir. Thank you so much to the chairpersons and thank you to the presenters for excellent videos. We now move on to our very interactive panel discussion on complications in hysteroscopy. And I would like to introduce our two moderators, Dr. Subhash Malia sir and Dr. Parendra Bharadwaj, and we have 7 very experienced panelists from all over India. May I have Dr. Subhash Malia sir's CV, please? Dr. Subhash Malia, Chairperson, Foxy Endoscopy Committee 2021 to 24, Member Specialist Board of NBE, Minimally Invasive Gynecology. Sir has various accolades to his credit. He's been a Managing Committee member of IAG from 2019 to 2024.
Thanks. We'll go to the next one.
Okay, and Dr. Parendra Bharadwaj, sir, is also IAG Managing Council member from 2023 to 25, and he has various achievements and awards to his credits. I would like to hand over the proceedings to our moderators and like them to introduce the panelists, please, sir.
Thank you, ma'am. Thank you very much. I think just one word about Parendra Bharadwaj. He is a great human being. Right. Now, coming down to our panel, the esteemed panel, may I invite Dr. Amit Azane. Amit Bhai is currently on the road on his way to Raipur. So I assume he is in a place where he has some signal. Amit Bhai?
Hi. Yeah, hi.
Yeah, Amit Bhai is from a place called Sangamner. Sangamner Che Raja is how we call him, right? Right. He is a renowned endoscopic surgeon doing a lot of work. Not only most of us are very lucky to be in the urban part. He is in the rural part of India, doing a lot of service in the rural area, and I wish him the very best in all his endeavors. Next, may I invite our next panelist, Amol. Amol Bhai is again. We have chosen a lot of people, from the urban. From the rural area. He's from a place called Chiplun. Very close to my heart because Chiplun is where our Konkan Railway also starts beyond Roha. So thank you, sir. Thank you very much. He is actually done his work from Warwick University, UK also. And he's worked as in the government sector. Currently, he's also in the private sector also. Nikam is a big name. Is a good name. We see a very nice background also in the behind. Sir, thank you very much for being in the panel, sir. Parendra Bhai, over to you.
Thank you so much, Subhash Bhai. And you are also too sweet, huh? So we'll start our panel. Let me just share.
When we have Dr. Anita, please introduce Dr. Anita.
Yes. Dr. Anita Mahe, she is a consultant gynecologist and a laparoscopic surgeon, and she did her MD from PGI, and she has done fellowship in advanced gynec, practicing since last 7 years, executive member of IIG Punjab chapter, convener of CRMS CHD, and overall she is a very good orator and a very good endoscopic surgeon.
I have to intervene and thank Anita. Anita, we had a wonderful conference in Chandigarh and in Ludhiana. Thanks to your team. Right.
Thank you so much, sir, for inviting me. Thank you for giving me this opportunity also.
Hi, sir.
Hi.
Dr. Divya here.
Next, our panelist is Dr. Divya Narasimha. She's a consultant gynecologist at Bilot Hospital, Chennai, and she is a Johnston medalist in Madras Medical College. And her field of interest is in laparoscopy. She has received the Best PG Paper Award from OGSS Icon 2010. Welcome, ma'am. Welcome on the board.
Sir.
And
Thank you for the opportunity.
Thank you. Next panelist is Dr. Jayesh Patel. Jayesh Patel is a director consultant of Arya Women Hospital, Memnagar, and visiting gynec endoscopic surgeon from SVP Hospital and NHL College and ART specialist in Ahmedabad, and a very good friend of all of us.
Jayesh Bhai is currently in a marriage. He will join us in the next 2 to 3 minutes. He is there in a marriage function. And Jayesh Bhai, again, last time in Endo ATM, we had a wonderful workshop. We had almost about 45 cases from his hospital, government hospital. And he did a lot of good work. He did a lot of good coordination. And really, thankful for his dedication and because getting a large number of cases is not easy for a huge conference. Jayesh Bhai, thank you very much for joining with us. Next, we have Dr. Shambhav. Again, from Aurangabad. Yeah, Dr. Sandeep is currently in a case and he is not able to join. He'll join us in the very next few minutes. One is in the marriage, one is in surgery. You just join us. Shambhav is from Sambhajinagar, Maharashtra. Very, very notorious, very notorious in sums. Abhi Sambhajinagar versus Aurangabad. So Aurangabad is now being called as Sambhajinagar. He's the past joint secretary of Aurangabad OBGYN Society, and we've had a lot of good conferences. All the Endo World conferences, Shambhav was the organizing secretary with Vikram and the whole team. Thank you very much, Shambhav, for agreeing to our request and being in the part of the panel. Right. Let me give the first word to Farendra Bhai. Farendra Bhai is the leader in hysteroscopy. I am his follower, so he'll take us forward.
So, let's start this panel. And me and Subhash has decided that...
Sandeep has just joined. Sandeep Bhai?
Wonderful.
Yes. Welcome, Sandeep.
Sandeep Bhai. Kemon ache? He's here. Right.
He's here.
Let's go ahead. We're already beyond time. Yes.
So me and Subhash has decided that we'll keep the panel like the moderator will be speaking less and the panelists will speak more, because we have seen many panels where the moderators are speaking everything. So simply we have kept a panel of no, Subhash Bhai has just shut his mouth.
He was indicating towards me. I could make out. Thank you.
So let me just start this panel. I'm just making it. One sec. So fine. It's a panel on complication of hysteroscopy.
Welcome, Sandeep.
Welcome, Sandeep Bhai.
Hi, Subhash.
We are two
Welcome,
good
Sandeep.
friend of all of you. Me, Farendra, and Subhash Bhai. And our panelists, we have already introduced Sandeep Datta Roy, Amit Tanjay, and Anita Mahe, Divya Madam, Jayesh Bhai, Shyam Sir, and Amol. So welcome all. So we'll start the panel. We all know that hysteroscopy is revolutionary science for gynec diseases, and it's gradually increasing its spectrum. Very important line, and it's very cost-effective and a time-effective procedure to treat most of the symptomatic gynecological pathology. But it has its own spectrum of complications, which are early and late. So we'll start our panel. So we really wanted to know, Sandeep Bhai, that is there any untold story which you really want to discuss with us? You all of you must have faced some complication, and we wanted you to speak it out so that our audience will be straight away benefited. And we'll have
I would just like to intervene here for 30 seconds.
Yes.
Yes.
I need everybody in this panel to, please follow like how you tell in the code. Jo bhi kahunga, sach ke siwa kuch nahi kahunga.
Yes,
Because
yes.
here we are here to share our problems. We are not here to say how good we are or how bad we are.
Yes.
We are here to share our complications, and it really needs a lot of guts, to accept our complications. Sandeep Bhai, no offense to you. First is yours. So we will like to hear from you.
Yeah, Subhash, I'll not talk about the perforation, fluid overload, and all these things. Like we all know all these complications. In last 12 years of my practice, I had four mortalities, two in laparoscopy and two in hysteroscopy. So in hysteroscopy, both these complications were air embolism. I should say because one patient I lost on the table and one patient died in the ICU next day. So what happened when we reviewed the cases? One patient we had found that she had some cardiac diseases which was not told to us before. So on the table, she like when we just started doing the hysteroscopy, like she collapsed on the table itself, and then like immediately we had a cardiologist call. Even so the cardiologist came
There's some network
embolism.
instability.
Sandeep,
Yeah.
we could hear you.
The moment, like the patient collapsed, the ETO2, everything fell down, and then SPO, everything was like within second was like almost zero. So this
Sandeep, you can just switch. You can just stop your videos and continue with your voice. By this way we can get your wonderful.
Yeah. So what happened is like patient immediately collapsed, and like when you reviewed the video, what we could see in the first case, one or two bubbles that actually entered into the there was a embolism. So this patient actually she died on the table. Then another case, the second case that I was doing, it was quite a long time back in the periphery.
Sandeep,
Yeah.
I'm just stopping you here at this juncture because let's make it a discussion. So you said that during your videos you have seen few bubbles which are going into the where it was going. It was going into the myomet in the Philippine tube, or it's going somewhere else.
Actually, this patient, not in the fallopian tube, it was going near the fundus. What I could see in the fundus, some area of the endometrium was eroded. I don't know whether the hysteroscope touched there or something, which I don't know, but it is in the fundal area, the endometrium was eroded, and I could see few bubbles going into that. So probably there was a air in the tube itself which was not cleared, and then probably it went through the hysteroscope, and then through the open vessels it entered into the this thing. This was the
create
first case.
Air embolism, you need a good amount of air to move into the the vascular tree.
Exactly.
Yeah, Anita, Anita, may I just intervene here? Anita, what is your take on this particular case? Now, he has said that most of us, let's be very frank, most of us, when we do, we have some amount of air bubbles. So next time, should we be very careful about this or not?
Exactly.
First Anita, and then I'll follow by Amit. Yeah, Anita, please.
Sir, I think the first and foremost is definitely the air purging that we should use. 90% of the time, it is the air that is coming through the tubing that have directly gone into the uterus through that thing. And most of the time, we have seen that what I have seen in one patient of mine when I was a PG student, the moment they introduced the histoscope into the cervix, the patient collapsed at that time only. So the most probably the cause may be the room air going to the cervix, so that may be the one of the causes. So whenever they say that whenever you dilate the ideally so we are going with the vaginoscopy, but when you are dilating with the cervical dilator, so you put
Anita,
the dilator, keep that in situ
Anita,
only and do not take it out.
Yeah, Anita,
and immediately
सच कहना, सच कहना, वेजिनोस्कोपी करती हो या डायलेटर पकड़ के करती हो?
नहीं sir, I have learned with vaginoscopy always. In fact,
Good, very good.
I refuse them to do it.
Yeah.
So
Amit
I
bhai,
always do
Amit bhai,
vaginoscopy.
your take. No,
Yes,
because you know what? Bhaskar
Actually-
sir has given us, 1 hour. He's been very magnanimous with 1 hour, but I think we are already short of time. So I think we'll just go first.
Yes,
Amit bhai,
yes.
your take on air bubble and embolism.
Actually, air bubble, what we follow in my hospital and in my practice, we used to do the first check all tubings, and first remove before introducing. Am I clear? My voice is clear?
Yes.
Because something is playing. I'm just sitting in the hotel for the dinner. Sorry for this. And we regularly keep a one person at where we put the saline bottles, and when we change, we used to attach two bottles.
we used to prefer a 3 liter. If not available, then we used to prefer a 1 liter and attach 2 bottles at a time, normal saline bottles. And we have to clear the whole tubing before entering into the vagina also. Before entering into the vagina, and one person keep eye on that bottles. And my strictly instructions are there. Whenever there is 100 ml of saline remaining, just close it. And
so Amit,
just stop it.
I'm just stopping you because we'll have to ask many questions. So
Surendra
the
sir.
important thing is that avoid dilator, because this dilator creates
Yes,
a
yes,
suction into the uterus, one thing, and which can
yes,
suck the air inside. Second thing,
yes.
what Sandeep has said, any pathology which is lying near the cornua or on the fundus are prone for air embolism and gas embolism. Please
Absolutely.
make it very
Yes.
clear, because they have a connection by which it can, anastomotic ovarian vessels, by which it can straight away move into the system. And these are the things which we have seen. So you should be very careful when you're dealing with the fundal and the corneal pathologies.
So if I can,
Amit,
if I can sum up
yes,
this,
yes.
whatever has been said is, first check all the tubings, let
Yes.
all the fluid come out. Do not allow any air bubble. If you see an air bubble, let the air bubble go off and then you insert inside. Secondly, as has been told by Farinder, do not over dilate it. Right. Third, check for all the tubings which you've already done. But whenever you are using 2 saline tubes, or whenever using 3 liters of fluid, as Amit has said, be careful that the moment you have about 150 ml, shout it out in the theater. Okay, whatever happens, sir, मैं बंद कर रहा हूँ.
Yes, yes.
That is very, very important. Okay. Now,
And
anything
sir,
else?
I would
Yes,
I want to add one thing.
Yes,
sir.
Shyam bhai. Yes,
Yeah.
Shyam.
Yeah, whenever we go outside our hospital, the stirrups are not that angle of the stirrups is more than should be 90 degree, or it's a 120 degree. We should make it first. Then the position, avoid the two flexion or avoid the Trendelenburg position. That is, we should do it first and then start the procedure. As sir said, all air bubbles should be removed and check the tubing, and we can the outflow we can open it. And initially we require a more pressure, that is more than 100. And what should be the pressure is mean arterial pressure, as low as mean arterial pressure or below that. So sudden rise of the pressure initially may cause an embolism. In this case, even less than 5 microns of the vessel is open, then within a minute, half liter of the fluid we can which will go in intravascular.
So I think we'll go to the next one, Farinder bhai.
And one more thing here, I had to don't use that bags also.
Yeah,
exactly.
The histomat should be used.
Histomat should be used.
Yeah.
As we use in laparoscopy as an
But
insufflator, then why to
70
use that pressure bag?
75% of hysteroscopies even today are done with
Yes.
not
Those
with
who are
But we
for a diagnostic procedure, I think we
one
can
should not
use the
use it.
pressure bag. But for an operative case, we should use a histomat, because the procedure is prolonged, and then we have to change the too many salines. At that time, we should calculate, and Euro bag that available Euro drape is available. Now we should calculate the how much is the outflow and what has gone in intravascular. So that
and avoid multiple insertions also.
Yeah.
But Subhash bhai, one should have to be shift on the, because we are not using fuspus inside the abdomen, na? While doing the laparoscopy, one should have to invest in the that histomat.
Yeah.
Now there is some issue with there is some issue with Dr. Farinder. He has just been logged out. He'll just join us in about a minute. In the meantime, till the PowerPoint was, my next question would have been, that whenever have you abandoned any case? Have you abandoned any case till date? Now let me ask Amol bhai. Amol bhai, have you just abandoned any case till date in hysteroscopy? In hysteroscopy.
Yeah. Last week, what happened is there was a myoma inside, and I inserted my resectoscope. First, I did a diagnostic, then inserted the resectoscope, and suddenly the cautery failed. So, but in between, there was a panicky situation. ये wire लगाओ, वो wire लगाओ. There's permutation, combinations. It didn't work. In between, the myoma at the base of the anterior wall got separated, and my myoma was completely free, and it is moving inside the cavity, and it was a 2 to 3
हिला के रख दिया.
2 to 3
So now,
centimeter, and
yes,
we were
yes, if I
fighting
may
to
stop you,
take
sir,
out
if I
that
may,
myoma.
yeah, if I may stop you here. Once he used the word that the cautery was not working. But mind you, when you say that the cautery is not working, your idea should not be to increase the voltage. Please understand, your idea should not be. You should always check your current, check your circuit, than increasing the voltage. Please understand this.
Yes, yes.
That is one basic thing mistake. Nahi chal raha hai, aur badao. That is the
No, no,
wrong
no,
thing.
no.
Right? Now, Farendra Bhai is back. Farendra Bhai, I've just started with the difficult anticipated surgery. Over to you. Yeah, I think, yeah, you were telling about the
myoma.
What happened?
We were fighting for 1.5 hours to take out that myoma, but we couldn't do it. So ultimately, I have to stop that procedure, tell the relatives, and then the patient posted for the hysterectomy in the next week. And last
What was the
Monday,
size of the fibroid? So what was the size of the fibroid?
it was a 2 to 3 centimeter.
Okay.
It
Sir,
was a big one.
because I will just ask, suppose you're doing a submucous fibroid or you're doing a polyp. Now, out of the two, in case, worst case scenario, you leave it behind. Which is the one that you would love to leave behind? You leave the fibroid or the polyp?
Obviously, fibroid.
Yeah, I think it's very well because the fibroid will not have the epithelial lining, whereas the polypoidal lesion will have an epithelial lining. There can be infective foci. Hence, even if you get stuck up, I think even if you leave the fibroid, it may come out. It may come out. The uterus will try to expel it out. Okay, right. Farinder, are you there?
I also had,
Yes,
can I
Subhash bhai.
share?
Yeah, please
Yes,
take
Anita.
over.
I
Please take
also
over.
had the same
Man,
patient.
I was a stopgap because you are not there. Please.
Okay. So I had a patient who has a 2 to 3 centimeter fibroid grade 1. She was referred in view of myomectomy only, but she was already had surgery. So there was a dense adhesions inside. So I went inside with a hysteroscope and had perforated. So definitely there was no distension, but I have to do it. So I went in for laparoscopy and then I removed laparoscopy.
No, we'll come down to what you आपने जो कहा है ना, like Dr. Puntambekkar's, anatomy. It comes 10 seconds prior to what we think. So you have come 10 seconds because that is the next slide of Farinder Bhai. Farinder Bhai, please take over.
Yes. So, fine. Already Dr. Anita has said that she has done a laparoscopy. Am I audible now?
One point.
Slide, please. Can you please change the slide, Farinder Bhai?
Yes.
Yeah.
Again, next important thing is, have you abandoned any procedure any day?
We just discussed that, Farinder Bhai. By the time you are not there, we just
Okay,
discussed that.
fine.
We'll go to the next
Wonderful.
slide.
Wonderful.
Next slide. Yes,
So
please
what is
take
this?
over.
It's a false passage.
Looks false passage. Wonderful. So what is your diagnosis is clear. How will you prevent? I mean, who wants to take this question?
I think we should abandon the procedure.
Divya is okay.
Yes,
Followed Amol Bhai, followed by Divya, because Divya is very silent.
Divya, madam.
Yeah. So the vaginoscopy approach actually helps a lot, and going slowly, let the fluid do the little bit of distension and increase the visibility. By that mannerism itself, we can easily distinguish between which is going to be your false passage and which is your true endometrial lining. And sometimes we see those two, like the septum, we just see two osses or two areas. We don't know where to go into, which is the false passage and which is the right one. Just going near that and increasing a little bit of pressure, I think, will open up the real passage a little better, and going down a little bit. And usually we find making these false passages in the posterior myometrium rather than the anterior myometrium, because we are really careful with the angulation. So waiting a little bit, it will open up the passage, and then going in would be better. So that's one way. If you've already made a false passage, to not go into the false passage again and do it.
Very good. And what are the risk factor? Dr. Amit? Amit, are you there?
Yes, I am here.
What are the risk factor in which you can expect that you may land up into false passages?
Risk factors are the angulation of the uterus, and that may lead to the false passage and the Asherman cases.
Okay.
And here, how can we prevent? We should have to avoid the use of dilators. We should check the before surgery beforehand the angulation, and without using the dilator, use 2.9 mm hysteroscope. And
Wonderful.
and
What Farendra Bhai is trying to suggest is, of course, you will do it. You will do a bimanual examination for sure. Definitely, a PV is a must. Nowadays, in the advent of hysteroscopy, we have forgotten our per vaginal examination.
No.
What he is suggesting is there a role of of ultrasound? He is
Yes,
in
yes.
difficult anticipate.
Yes.
That's what Farendra Bhai is asking.
Definitely.
Yes, definitely.
I think the use of the tablet misoprostol 400 microgram prior to the surgery and the non-touch technique, no speculum, no valcellum, and we are going by almost now everybody is going by a vaginoscopy, and we thought that the cervical canal is rounded as a perfect canal, and it's a elusive. Sometimes it rotates to the right, sometimes it's left, and often posterior ridge is there. And if you force the hysteroscope at that moment, that posterior ridge will go into the myometrium, and the crisscross fibers that assumes like an Asherman's, and we come out and sometimes diagnose an Asherman syndrome. So I think by doing a vaginoscopy, non-touch technique, we can negotiate into the cervical canal, internal os, we can negotiate, and we can have a beautiful view intrauterine.
And also one point here to add that you have to wait just go inside the external os and just behind from the internal os, because cavity fills from inside to outside, and your water pressure dilates the cervix.
Yes.
And just follow that.
Correct.
Whenever you feel like there is a resistance, you just come out few millimeters behind and go ahead. Then when you go 2 steps ahead, come 1 step behind. So that is the technique of simultaneous dilatation. And obviously misoprostol is going to help it.
So in a nutshell, what Amal Bhai said, Shantamana करायचं है. So be very.
So all these things, pre-operative prediction by doing a clinical examination, history of a patient, high-risk patients are Asherman disease, previous failed entry,
Cervical fibroids also.
cervical fibroids. I mean, the video which I'm showing is almost at the level of internal os. There was a big adenomyoma which was deviating the cavity. You can easily land up into false passage. So with your clinical experience, with your experience in hysteroscopy, sometimes you can find out the natural passage or the exact entry. But in cases of Asherman, if you have land up into a false passages, as sir has said, that you can abandon the procedure, and then later on you can plan this patient, or especially on the day of menses or last day of menses, where the blood and can direct you towards the canal, and misoprostol has certain role, and you can reach into the cavity and complete this procedure. So anything you want to add, Subhash Bhai?
Summarizing what Farendra Bhai has said, that in such cases always, you do your per vaginal examination, you do a PV, very good bimanual examination. Secondly, use of misoprostol will be helpful in anticipated failure cases or difficult cases. Again, as Farendra Bhai said, on the last day of menses, if you do it, it will be a very good one. Again, use of an hysteroscopic Caesar also. We have seen a couple of videos from Nitin Shah and also Farendra Bhai, where you use a Caesar slowly, either with a Caesar or with a grasper. Just open it up. You just open it up, and that's what you see. That's one thing which is rightly said. And of course, ultrasound, as we all know, in a short deviation from the topic, we have a very good ultrasound workshop also coming up in Mumbai at Mahatma Gandhi Jaipur, also coming up in the month of September. I think we should.
Next month only, in the month of February, 17, 18. Yes.
Now, again, taking over this case. Now, starting from here, Divya, can you just guide us, followed by Sandeep? How do we do, and how are we going about this? Farendra Bhai, can we start from the beginning? Can we start?
Yes. This was the in the summary of the same previous false passage, that these are the risk cases: cervical atrophy, cervical surgery,
and to add on to what Amol Bhai said, whenever you do not see, come back. In hysteroscopy, there is no place, Dikh nahi raha hai, aage badho nahi. Aage badho doesn't come in this. There is no heroism here. Stay back, watch, allow the water to distend, and then you go.
Exactly.
As you would know, a very small movement in hysteroscopy is a big movement on the screen. Hence, your hand should be very, very careful, very, very precise movements. कहना आसान है, करना मुश्किल है, but I do understand that. But still, that's what we normally follow, right? Now, Divya, the next case to you, Farid, I will take you over. Yeah.
Yes. So, Dr. Divya, it's a very clear-cut case. A 32-year-old patient undergone hysteroscopic myomectomy under general anesthesia. Patient had a hemoglobin of 6 gram, for which she received 3 units of blood. Now the HB is 9.4. During the surgery, her temperature has gone down, SpO2 has fallen, hypertension, tachypnea, tachycardia. We all know that what is the diagnosis. So, Dr. Divya?
I had a similar patient, sir. When he asked, have you ever abandoned? I had abandoned once down. Yeah. It was, actually the hysteroscopy is the one case where we are happy to even abandon at certain times.
Yes, yes.
I had a similar patient. We had treated that lady, our very own in-house nurse. We had given her 4 transfusions. Then we had taken her up like second day after the transfusion. Immediately, as soon as we went in and we started dissecting the first myoma, the first cut itself, she had so much of frothy sputum coming out, and she went in for pulmonary edema, and the volume overload was instant. I don't know why, but because then we understood, talking to the cardiologists and everyone, we understood that these anemia treated patients, the hemodynamically, they are totally unstable. The volume overload is already there because of our transfusion, and the blood is so thin. And we keep pushing in a lot of more water through the hysteroscope is creating a lot of pulmonary edema. So that's when I realized that if you have transfused and taken up a patient, I usually give them some time before we go into the next patient.
If I may intervene and ask you, is there one particular thing during the surgery which you will use, which will help you in detecting a early pulmonary edema? And that would be?
Fall in ETC2.
No.
This parotid swelling is there.
Parotid swelling is later on.
Parotid swelling, it comes down
Parotid
slightly
swelling.
later. I think the first thing that you do is put in a simple pulse oximeter. The moment your SpO2 goes less than 92%, you have to start thinking in terms of your pink frothy sputum and everything. Parotid sign would come slightly late.
Yes.
The moment your SpO2 falls less than 92%, that means there is some.
In fact, you should not wait for 92. Suppose a patient is maintaining, if you are operating in GA, maintaining a saturation of 98 to 100%. If it goes below 96, and you suspect that this is a high-risk patient, had a blood transfusion received, you are doing a thick muscular septum, big myomas, stop there and there only. Reassess, allow the anesthetist to settle everything, and then again you can restart.
Yeah, if I may add one patient, especially in this type of cases, like where you give blood transfusion and take patients for surgery, always give Lasix before surgery, because whatever you do, some amount of fluid goes into the vasculature.
100%.
So that itself actually gives you some
Dr.
protection.
Sandeep, in fact, I would say, don't post patient for major hysteroscopic surgery immediately after blood transfusion.
Exactly.
Very much.
The count which is
We could have
increasing.
given GNH or an
Yes.
also.
Buy time, that is very important. You are giving blood just because the hemoglobin is 6 temporarily. You make them aminoric by giving GnRH, OC pills, or whatever you want to give. Buy a time of 1 month, stabilize the patient, and then post them for surgery. As Dr. Sandeep has said, giving early Lasix and prophylactic Lasix doesn't make any difference. You can put a catheter, give a Lasix, and proceed for surgery. As most of us nowadays are operating with underwater saline bipolars, resectoscope, most of us are not using glycine. Glycine has its own way of complications. All of us have stopped using glycine 10 years back.
Yes.
And that is why we are not discussing today. Nowadays, we are discussing fluid overload, and it can be easily tackled. So my next question is that, I wanted to show this small video. It's my boss, he taught me the,
ABCD.
Yeah. See, that's a fluid balance. He's Dr. Nahata, my boss, who taught me most of my hysteroscopies.
I think Jamal Kudu was based on Abrar.
Yes. Jamal learned from him only.
Exactly. Abrar learned from him only.
Yes. So my next question is, what is your own fluid guideline?
Yeah, who would
Anybody?
like Shambai? Shambai
My-
would like to take this case?
Yeah,
Anita, please. Anita.
So my guideline is that 15 minutes, sir. If my surgery is going beyond 15 minutes, I alert
Yeah.
everybody,
Very
because
good.
I know this is my time. This time might be differ for somebody else also. And
Alert का मतलब आवाज करोगी या
नहीं, anesthetists को बता दूंगी सर, anesthetists को बता दूंगी कि you check on vitals, because if it is going more than 50 minutes, because 90% of the time, since I am a freelancer, I don't have histomat everywhere. So I work on this thing, and not every time I have the person, a very guided person, to have a fluid deficiency.
Farendra bhai?
So
Yes.
Now you get why I told जो भी कहूंगा सच के सिवा कुछ नहीं कहूंगा।
बिल्कुल,
इससे पहले ही गीता पे हाथ रखा था।
हाँ तो रखा है सर, बताया ना कि मेरे पास नहीं रहता है सर, तो आई हैव टू so I keep my time, so that because I know that I'll be able to finish surgery, or what is the fluid overload will, so at that time I alert my anesthetist that
Yes.
this is going to be a challenging case or whatever it is, so keep on telling me. And second thing is, I carry this V-shaped bag with me. So whenever I go outside for performing surgery, that almost keeps me in check, that what is the fluid going outside.
Shambai, what will be your guidelines? What will be your
Yeah.
fluid guidelines? Anita has
Yeah,
given hers.
we should have a count of the fluid, because the surgeon who is operating, who is doing a septum resection or some other surgery, he cannot measure and what is going on the floor, what should be the fluid in the floor. We cannot measure
लेकिन
it.
मेरे
So we have
थिएटर में तो
that
स्टाफ ही
bag.
नहीं है बॉस। श्याम भाई, मेरे थिएटर में स्टाफ कम है, कैसे करूंगा मैं ये सब?
Yeah, you should have, whenever you are changing your bottles,
Yeah,
then
this
you should
V-shaped drapes are very
aware
useful.
all the OT staff how much bottles you are changing. That is the first thing. And you should have a use in a urology drape that could guide you.
V-drape.
Drape. That will guide you how much is the outflow, and that will prevent the TURP like syndrome. That will prevent the syndrome. And if your normal saline using it, the significant volume is 1.5 liter deficit is there, 1 to 1.5 liter, then you should stop the procedure.
In a cardio normal patient.
Normal patient.
Normal
Yeah,
patient,
yeah.
1.5
Yeah,
liters is the maximum limit. Okay.
Yes, yes.
Now,
And
let
The
me
threshold, sir,
Well,
the threshold for us abandoning a procedure or stopping a procedure usually changes. If we are in the home ground, if you have a good anesthetist, and if you know that if there is some problem, you know that there is a guide for you to take, to help you out when there's a problem. We're a little brave. At the same way, when we have something like a grade 0 myoma, which is just dangling there, we know that there's not much of an absorption.
Divya, not
then also
everybody,
we take more time.
Divya, not everybody is lucky to have her husband as anesthetist.
No.
We should,
He doesn't
sir,
operate with
at
me.
the cost of the patient, we should abandon the procedure if any warning signs are there, and we can finish the procedure in a later date.
Shambai, you talked about his warning signs. Myself and Farinder, we do not know what are the warning signs. Can you please tell us what are the warning signs?
If the diastolic blood pressure, if is more than the 15 millimeter of previously recorded, that is one thing. You said already said the saturation, which is dropping with the general anesthesia patient is there, and the fluid deficit you are counting a normal patient at the more than 1000 ml, and if somebody is using a glycine, the significant threshold is around 500 ml. So very cautious while using a glycine. And
Glycine,
now everyone has
500 ml. I may not agree, because sometimes even if you go up to about 1 liter also, it's okay. But again, Dr. Farinder has shown us a very nice pink color thing. Can somebody elaborate on the pink color thing? Or Dr. Farinder, could you please yourself tell us about the pink color wala? Yeah. Can somebody just elaborate on this?
This is a floor suction that keeps on telling you that on the floor what is there.
Exactly. I mean, all these pictures will help you in calculating the deficit. But as a surgeon, hysteroscopic surgeon, you know that how much fluid you are pushing into this particular case. So you should be very careful. I have seen, there are certain technique. We are not going into the details, but there are very high risk cases, especially a muscular septum and a myoma, which is more of a type 1 or 2, are prone to get more of the fluid into the intravascular system. I've seen very many surgeons operating right from the base and then removing the chip. I am very say like the vessels, the venous channels are more into the base. So targeting the base right from the beginning is not a good idea in cases of myoma. And you should be a decently fast enough surgeon to finish this thick muscular and myomatous surgeries. This is what I mean to say. In the beginning, you should not start with a big myomas and a big muscular septums. So please be careful. And fluid overload, we all of us have seen mortalities. So make your own protocol, work with your team, especially if you're a freelancer, you have to be very careful when you're dealing with such a complicated cases.
Yes.
Sandeep,
So
can you please?
whatever ways we have to control the flood, it doesn't work like the Mumbai or Chennai floods. Whatever you have to measure, it doesn't work. That's the truth.
Correct.
Mostly we get stuck once we know that it is not going to cause a problem. We just go on with the floods. Only when the water enters the house, we understand that yes, we are caught.
So that's
So I think those life lessons, those 2-3 things, not to post these patients, totally say no. Saying no is one in this area alone is okay with us. Our ego has to come down a bit.
Sandeep, are you there? Sandeep bhai?
I still wanted to hear from Jayesh bhai. Jayesh bhai has joined.
जयेश भाई शादी में है, अब भी शायद मैं एक बार फिर फोन करता हूँ.
No problem.
Okay.
And
Great.
Amol bhai is there?
Yeah,
Yes,
Amol
yes.
bhai is there.
Amol bhai,
Yeah,
this
see me.
question is for you. Just see this video.
In the meantime, Sandeep, can you join us? Sandeep? Yeah, Amit bhai, party शुरू हुई क्या रायपुर में?
No, I am here.
अच्छा, thank God. I hope Dr. Rishikesh is also there with you. Rishikesh Pandit,
Yeah,
great
Dr.
surgeon.
Rishikesh. Yeah, Dr. Rishikesh is also
Namaste
with me.
Rishikesh. Namaste Rishikesh.
The cavity is completely filled with adhesions.
Yeah. Subhash bhai clearly describe when you're seeing lot many white fibers, crisscross fibers. I've heard his lecture. Exactly, you're not getting any. And this was a case of Asherman.
Yeah.
Rishikesh, if you don't mind, you can also join us, Rishikesh, because
yes,
Jayesh bhai is also not aware. We would love you to have. Please do join us. Please accept our request.
Rishikesh.
Thank you, sir.
Dr. Rishikesh Pandit is a fantastic surgeon, very good radical surgeon from Aurangabad. Naitari. Nagar Madhe. We have a big infantry there in Nagar, na?
The surgeon is, going again, coming back, identifying the landmarks, cervical canal, rugosities, and then going back whether he or she is going in a correct plane. He or she, it's me only. All are my videos. So, fine. Again, I'm coming back and identifying myself whether I'm going in a correct plane or not. Because to me, it looks like a false passage I'm entering, but still I have to finish the surgery. So, as I said, I'm going to perforate
the adhesions are there.
Yes, it's a false passage again.
I am reminded of that, the ad from, laga, nahi laga, laga, nahi laga, ab laga. Hopefully it shouldn't be ab laga in this case.
And then in the abdominal cavity. Fine.
Oh,
laga.
I have done the same also.
No, everybody.
There
Everybody
is nothing. As Dr. Samir Pradhan says, you have to always be, very, very, very truth in whatever you're doing, in terms of life. He will ask you the same question. Such batao. That's what has happened now over here, right?
So again, how will you manage if a perforation you have created?
Yeah, who will take this? Who wants to take this case? Sandeep bhai? Yeah, please. Amol bhai.
Yeah. See, the diagnostic laparoscopy has been done. If there is a perforation is very small, nothing to worry about. You can just leave it. If it is actively bleeding, you have to take 1 or 2 small sutures. Figure of 8 sutures can work. And firstly, abandon the procedure.
Amol sir,
Hysteroscopic
when you said that it's a very small one.
No,
how do you
this video
define
is
this
different,
small?
and the previous video was a different video.
Oh.
The previous video was just you have gone into the false passage and you have perforated. This video is different.
Energy source. Amol sir,
without energy source. That was
very, very
with the
important,
telescope.
but that really matters. Your use of energy source versus use of a scissor or just with a scope really matters, because all the three are different. When your management comes, it's all different.
Yes.
Yes, anybody else? Shambai?
The perforation, if it is caused with a simple dilator or with a hysteroscope, not using any energy source, and it's a small perforation with a dilator, then we can observe just in the if there is no bleeding, or we can put a scope. If there is a simultaneous laparoscopy is going on, then we can see the if there is a bleeding, then we can coagulate or take a suture it, or just there is no bleeding, we can observe in the ward, give the good antibiotic course, and then just an observation. But if it is by electrode or electrosurgical burn, then it should be bowel tracing should be there, check for the bladder injury, any vascular injuries there, and that should be deal with the same setting, or even laparotomy is needed, should be done in the same setting.
Shambai, if I may just intervene, in practical solutions, vascular injury with this is not very likely. Okay, bladder injury with this, unless until you are in the lower cervix and anteriorly, otherwise not much likely. Rishikesh, will you tell us your views on this, Rishikesh?
You can do the picture with the one scope from above and one scope from the below. So that you
पैसे नहीं है,
can
पैसे नहीं, आपल्याकडे पैसे नहीं है. एकच scope है, एकच scope है. Oh, बोला.
We can see.
While you can open the scissor vertical and then give transverse nick. Okay. If you just go on giving the transverse incision, I feel that you may directly.
Farendra, can you just replay the video?
Trans elimination is there. There's some elimination in the we can see, or we can coordinate with the laparoscopy person, where I'm at least there's a trans elimination from the hysteroscopy. Then we can just
or under ultrasound guidance also we can it can help, I think. Especially Escherman, we always prefer doing. I prefer doing in ultrasound guidance.
Farendra bhai, can you please guide us over the ultrasound use and this Escherman, because I'm not very well versed with this.
Yes, in cases of grade 4 Escherman where there is no cavity, it is very difficult to find out whether you are going into the correct plane. See, yes, of course, water can guide you. Okay, I mean, here you are entering near to the serosa, so it can definitely better. The ultrasound is much better than your laparoscopy guidance. That is for sure. It can guide you that you are going into the wrong plane near the serosa, and that's not a correct plane. But going into the correct plane in case of grade 4 Escherman is very difficult with ultrasound. Again, I mean, I'm going to show you another case. In such cases, you all have to take the consent of, SOS laparoscopy, because if anybody of you is working in corporate, the charges straight away goes in a different level. See, you are doing a hysteroscopy, which might be costing around 35,000, and suddenly if you need to put a laparoscope, the charges will straight away goes to 1 lakh around. So how you are going to explain that beforehand to the patient? So the counseling and the SOS laparoscopy in all high-risk hysteroscopy cases should be counseled to the patient. And I might have to put a laparoscope as well. And pertaining to this false passage and high-risk cases, as we have said, it comes with experience to go into the correct plane. You can use last day of menses. If there's no menses, ultrasound guidance, and expert surgeon to be needed in dealing with such cases. I'm going to show you another case. This was an abandoned case. Grade 4 Escherman, multiple times hysteroscopy was tried and people have gone into the false passage. And luckily, she has given us a last chance that, if we can try. So we have taken a laparoscopic guidance. We have assessed the fluid, assessed the tubes and ovary. And as you can see, the hysteroscopy view will show you there's no cervix at all. See, there's no portio vaginalis of cervix. So there was only a simple dimple, and you will have to negotiate through this dimple into a grade 4 Escherman, which is very high-risk cases where you can perforate again.
Yes.
So in such cases, yes, we have taken a laparoscopic guidance. We were using ultrasound guidance. I am not able to record that ultrasound guidance. But here we are working in with our experience. Luckily, my team has a very senior hysteroscopic surgeon, so we get all such kind of referrals. So in this case, even we have perforated, as Dr. Anita was saying that she had done, and then sutured it, and then again tried, because this was a last chance. So it's the same thing we also did, but sometimes it's just a failure, and you'll have to accept. Sometimes you may not be able to create any cavity. So this is all what I can say about this perforation things. And wherever there is
sometimes these postmenopausal ladies, when they have a small, very short uterine length, sir, there also the chances of perforating with just your scope itself when you go also is high, because the os, negotiating the os also is a little difficult in those
it's a difficult thing. Yes.
A little more patience when we do postmenopausal
encountered,
uterus is important.
Farendra bhai, what I
Yes.
encountered is those patients with the previous LACS, who has many times people take a bikini incision, the cervix gets pulled up. And that time the diagnostic or anything, hysteroscopy is very difficult because the cervix is just pulled up. That time also we have to take care of all the things of the preparation, like mesoprost and all. It helps.
Yes, correct. Very nice. And this is the same thing which Rishikesh was talking, your scissor movement. It has to be transverse and vertical. So, these are very important things to negotiate and to enter an amount of pressure. But in spite of that, sometimes in very high risk cases, you can still do perforation. As we say, the first sign of perforation is sudden loss of visibility. This slide was given, Subhash was talking in one conference, and I said, yes, it's very important. Sudden loss of visibility, don't consider always as a perforation. Check your irrigation system. Check your inflow tubing. Suddenly there can be a kinking and, you have lost the vision and you are suspecting there can be a perforation. And now, of course, you can suspect a perforation in the end.
And as put by Farender, think of common things first.
Yes.
Check for the tubings, check for the fluid, check for the cervix, then go inside, and perforation should be the last. Your index for suspicion of perforation should be high, but the chance of perforation are always less. Think of more common things like the fluid. Even the attachment of the fluid is gone, there is a kinking of the tube, the fluid is over. Think of these common things first. Secondly, I think I'll just take a detour because Anita, in the meantime, had spoken about ETCO2. Now, Anita, most of the cases when we do hysteroscopy, you're a slightly, on a joking note, a slightly posh surgeon, you go to big hospitals, you have ETCO2. Not many of us, Amol Bhai, and Shyam Bhai, and many others will say that we also work in posh place, but kya hai ki paisa nahi parvarte. It is not very feasible to use a ETCO2 for every case of GA, So what my point is again, if you have an ETCO2 and you attach an ETCO2, your ETCO2 goes down. That is your first sign of an embolism. Whereas your saturation of 92%, 90%, 80, 98%, which she said would give you more of a pulmonary edema. Now, that is the only case in when you have an ETCO2. If you have an ETCO2, attach it, because that will be the first thing that you would like to know about the embolism part of it. Now, coming down to the next part of it. Now, I think as we have said, the practical, what we have done, what Dr. Farender has done, he's managed all the PowerPoints, the videos, and everything is Dr. Farender. I am just the ghusa, ghuspe to me. Okay. So the point is again now is practical solution. I think we all need practical aspects. We are not much interested in theoretical aspect, but what are the practicalities? That's why we are more stressing on the practical aspects over here. I think the next point over here, Farender bhai, the next thing is.
Next is another important, I just wanted to show all of you this video. That's again an impending perforation. But if concentrate here, can you see my cursor? Suddenly you will see a movement of bowel here. That's a near perforation. With experience, you can really make out that you have very close to the serosal layer.
Yes.
Suddenly you can see. Again, I'll show you. That's a very
Amit bhai.
Yeah, we have
thanks
to
to
see
my
many
teacher,
times.
Is he there, Amit bhai?
Nahata.
Amit
He has
Yes, I'm
given
here.
us a guidance. How can you deal
yes,
in such a difficult case?
One point I want to add is,
Yes, Amol bhai.
yeah, when we are doing a hysteroscopy, always see the ultrasonographically UCL length, and when you are going inside, how much you are you have gone inside. You must always aware of that. So the perforation happens when you go extremely inside, without knowing you have gone inside. So the ultrasonographically the UCL length is always you should keep in mind when you are doing any procedure.
Correct. So as you grow in the field of hysteroscopy, you suddenly realize that you need to do your own ultrasound. And it is extremely important when you are going into the complicated surgeries and you are excelling in the field of hysteroscopy. You should do your own ultrasound, assess everything, correlate with your clinical finding, correlate with your intra finding, and then teach and spread the knowledge of hysteroscopy everywhere. So this is what is our take-home message, and I think we thank Bhaskar Pal sir, all the organizers.
Before we end, may I invite Bhaskar Pal sir and if Sanjay Patel sir is, I may call Sanjay Patel sir also to give some tips, because we are not the right moderators, we are the middle level moderators. Let's call the experienced ones.
Experts, yes.
Yeah.
Dr. Sanjay Patel sir and Dr. Bhaskar Pal sir, if you can please join us.
I'm joined only. I'm here.
Join, matlab, sir.
I am here. I am here. Means before you all end, I want to thank all of you, and I want to remind you that the next one from next month we are going on to the second Wednesday of the month at 7 to 9 p.m. And the final one, the 8th one, will again be a 3-hour episode with 2 master lectures. And so the next program is on 14th of February from 7 to 9 p.m.
Yes, sir. So thank you very much, sir. And I would like to thank, any of you would like to give, final comments. Sir has been magnanimous. Sir has given us 2 minutes extra. Some few points that you would like to, pass on to our, because as I said, we will need only some practical tips. Starting from you, Amol Bhai, senior most. Amol Bhai.
Yes. What I experienced is during hysteroscopy, the lateral movement should be minimal, so that you can. We have not discussed about the instrumentation damage. Many times when you do hysteroscopy, to and fro movements should be very controlled, but lateral movement you should be always avoided. I have damaged my scope because of that. So even one time, my this cutting during the resectoscope, my Collins knife got cut. So too much lateral movement should be avoided.
With your permission, may I just add one line when you said about instrumentation. Now, whenever we're doing an hysteroscopic myomectomy, the biggest mistake that we do is we think that the myoma is getting cut because of our mechanical pressure. Mind you, please understand, the myoma doesn't cut. It's not a complication. It's actually fully about the instrumentation part which you said that. So what happens is, with the current only you cut it. You don't use your mechanical power there, because it's a very thin one and you lose it. Once you lose it, 20,000 rupees is gone. So sir, please understand that this is one thing. I'm sorry to interrupt you. Sir, please take over, sir. Please. Amol, sir.
So it is a whole means mechanism of the instrumentation, current, and your force. So all these movements has to be very precise. If you apply more force, you are going to damage it. Before applying current, you must see that because the depth is so small. Depth perception is most important, because nowadays the people are operating in 3D, but hysteroscopy is always 2D. So depth perception has to be good. So then only you can avoid complications.
Right, sir. Shambhai, your take on it, your final couple of points.
While doing resection of any endometrial resection or a myoma, are you all sending this sample for a histopathology examination for a hysteroscopically removed? So I think that every strip, whatever we are taken from the hysteroscopically, like a strip, endometrial strip, and we should send for the histopathological examination.
Okay. Sandeep Roy, Shandeep. Probably he is. Anita ji.
Sir, for me, I think whenever I'm doing difficult cases like for Escherman and all, I always try to do these patients in a place where I have a ultrasound guidance is always there. So one is this, and always take consent for the patient for two-stage surgeries definitely, and laparoscopy always. Even if a diagnostic you are going, always take a consent for laparoscopy.
Very important.
Yes. Divya.
Yes, sir. When when I am doing any kind of a flat myoma, a big myoma, I definitely want to take a second sitting sometimes, or I usually counsel the patient that I might not be able to finish the entire procedure. And I definitely don't take any of these anemia treated patients immediately within those 2 or 3 weeks. However much the surgeon
Your hands
wants
have
to
burnt
push.
very badly, I think, Divya, with this case.
Yeah.
That is why.
The
very
surgeon's
important
husband
thing,
was a cardiologist, so he came rushing into the hospital and he helped us out.
Yeah.
I don't know. I was like, I was so happy that day that your Madam Ramya ma'am, your husband is a cardiologist.
Yeah.
So
Amit
he
bhai?
came and helped us out.
Amit bhai?
Amit bhai,
Yes. The first thing is you have to wait, follow the creases and wait where it ends. Okay, and wait till the cavity opens the door for you, and then go ahead. Okay. Then second thing, don't give head low while you are doing a hysteroscopy. Then third most important thing, ask your anesthetist to keep your mobile and book aside for 10 minutes while you are finishing the hysteroscopy.
Absolutely. Absolutely.
These are the
Anesthetist is your biggest friend.
Yes.
He could turn out to be your nemesis also sometimes, but then in hysteroscopy, I would always shout
Be
at
in very
anesthetist,
good terms with
please
them.
stay back. Absolutely. Now, good terms, husband is anesthetist, okay, da. Right. Rishikesh bhai? Rishikesh bhai?
Nothing from my side.
Arey, kai bhai? Right. I think I have to with the permission of a couple of points which I would. First thing, I think whenever we do any complication, I think call for help is a must. You ask your senior, keep always your senior person in good books. You call for it. Secondly is, I think please attend. Unlike your laparoscopy where you always feel, please understand when a laparoscopic case is done, whether it is a simple diagnostic one or a radical hysterectomy, the whole theater is always geared up. The whole theater is geared up. The anesthetist, the staff, the surgeon, everybody are. But the problem that the common problem or the approach or the attitude of everybody when it's hysteroscopy, isme kya badi baat hai. But that is where your mistakes occur because everybody are taking it very, very lightly. Ladies and gentlemen, let's resolve today that everybody will take it very, very seriously. And hysteroscopy has the maximum number of mortality and morbidity is not laparoscopy per se. So please always have a good look. Everybody should be alert. And secondly, as I said, please do attend webinars, and your workshops. Your live workshops make hell lot of a difference. You're talking to your peers and seniors also make it, and attending webinars like Endovision also makes a lot of difference. So please do join us on every second Wednesday, every second Wednesday of the week. And the last one, as Bhaskar said, that will be a mega one. We started a mega, we'll go with simple one, and then the mega in the end. Okay. Ladies and gentlemen, thank you very much, my dear friends, for joining me and sparing your time.
Thank you.
And now first thing I will send off is Amit and Rishikesh. We have been waiting for quite long for the party to begin there. Now they can
No,
go.
we have to travel for 250 kilometers.
अरे
250
बाप रे।
kilometers we are from Raipur.
गाड़ी में भी और पेट में भी डीजल डाल के जाइएगा।
We are the opening batsman for the next day.
Right.
We are the opening batsman.
Best wishes for the very wonderful workshop tomorrow at Chhattisgarh, Raipur, and best wishes for your surgeries also, and best wishes for the coming up IAG. Sorry, sir.
Good to see Rishikesh. Good to see Rishikesh, and thank you, everyone. Thank you. I can see Anita.
Thank you, sir. Thank you,
I can see Amol. I can see Dr. Sham. I can see Divya. And thank you. You're on one of your operating road trips. Looks like Amit and Rishikesh.
Thank you, sir. Thank you, sir.
Thank
you.
you.
Thank you
so
very
much.
much. Thanks, everyone. And
Dr.
thanks for
Pushali, thank you very much.
Thank you, Bhaskar sir, for giving us.
Before you give the vote of thanks, I would like to thank you for taking a lot of.
No, this is not vote of thanks. This is personal thanks.
Yes.
I saw Rishikesh, and that's why I was not expecting Rishikesh here.
Thank you, Rishikesh.
Thank you, bye. Thank you very much.
Okay.
Thank you.
Bhaskar sir.
Yeah.
Bye-bye.
So,
Thank you.
thank you to all the
Bhaskar.
faculty. Thank you to our speakers, our chairpersons, our guest of honor. Thank you to our moderators, our panelists. This was an excellent session. Last but not the least, thank you so much to Bhaskar sir, for who has been the visionary and has formed Endovision. And I also would like to thank our academic partners, Alembic, and our technical partners, Conferences International, and our delegates for joining in today on a holiday and enjoying 3 hours of complications and complex surgeries in endoscopy. Thank you very much. Good night, everyone.
Thank you very much.
Thank you. Thank you.
Thank you,
Surendra bhai,
Subhash bhai.
thank you very much for all the efforts. Ravikant sir.
Thank you, Subhash
Ravikant sir
bhai.
has been from the starting till the end. Thank you very much, Ravikant sir. He
Yes,
is
thank you, Subhash.
he is the chairperson of the Karnataka State Endoscopy Committee. Thank you very much, sir, for that wonderful opportunity, sir. Again,
I must say, in this panel, I think the panelists have spoken more than the moderator. Yes. Thank you.
Thank you, Farendra.
Thank
Thank you
you.
very much.
Thank you, sir.
Sir. And Team Alembic. Thank you very much, Saurav, Himanshu, the whole team of Alembic.
Yeah,
for
we
this
need to
wonderful opportunity.
thank Team Alembic and Team Confidence International.
Yes, sir.
And I think we can go
offline.
We can go offline now. Himanshu, are we offline?
Recording stopped.
Yes, sir. Now we are.
Okay. Say hello to everybody. Subhash, Farendra, we are missing you all.
Oh my God.
Arey, sir.
Bye.
You had